Bom dia e muito bem-vindo a todos ao terceiro Simpósio Internacional de Cirurgia, Robótica, Colorretal do Hospital Moinhos de Vento. Meu nome é Thiago Léo Guese, eu sou o chefe do serviço de coloproctologia do Hospital Moinhos de Vento e o responsável técnico deste terceiro simpósio. Eu gostaria de antemão de agradecer dois colegas do nosso comitê técnico, o Dr. Vitor Binda e a doutora Heloísa Guedes Musnich. Aproveito também para agradecer os nossos patrocinadores, sem os quais não teria sido possível a realização deste nosso evento, a Johnson & Johnson e a H. Stratner. Estamos na terceira edição do Simpósio Internacional de Cirurgia Robótica Colorretal do Hospital Moinhos de Vento, e neste ano nós decidimos focar na abordagem através de diferentes estratégias para o tratamento do câncer do cólon direito, do câncer do cólon esquerdo e do reto, tentando discutir aspectos de técnica cirúrgica, dicas e truques, manejo perioperatório e treinamento em cirurgia robótica coloretal. Nós temos online participando 225 inscritos, e este ano nós temos o prazer de contar com 6 convidados internacionais, dos Estados Unidos, da Inglaterra, da Espanha, da Holanda, Portugal e México, que serão devidamente apresentados ao longo do nosso evento. Temos o prazer também de contar com 3 convidados nacionais, de São Paulo, de Minas Gerais e da Bahia, além de outros tantos colegas que fazem parte do nosso serviço de coloproctologia do Hospital Moinhos de Vento e outros colegas também do Brasil. Esse evento ocorrerá no turno da manhã de hoje, das 8h30 até o meio-dia e 30, sem intervalo. Embora nós tenhamos desenhado este evento para ser realizado em inglês, dado a nossa plateia ser na sua imensa maioria do Brasil, com alguns países também da América do Sul participando, e por nós termos também alguns palestrantes que são de Portugal e de países de língua hispânica, a gente fará parte do evento em português, e uma parte, obviamente, com os nossos convidados internacionais em inglês. Então, sem mais delongas, eu gostaria de já passar para a nossa primeira das 3 mesas redondas que nós teremos hoje, que será uma mesa redonda dedicada ao câncer do cólon direito. E aqui nós vamos apresentar 3 aulas diferentes, com diferentes visões, diferentes abordagens para a realização da colectomia direita robótica. Por uma questão de conectividade, nós vamos realizar uma pequena inversão na ordem do nosso programa científico. Então, nós iniciaremos apresentando a aula do professor Danilo Miskovec, que originalmente estava prevista para ser a terceira. Então, o Dr. Ramon passa a ser a terceira apresentação e não a primeira. O professor Danilo Miskovec, ele é um Consultant Colorectal Surgeon do Hospital St. Mark's e também é provavelmente aquele que tem a maior experiência em cirurgia robótica coloretal na Inglaterra atualmente. O professor Danilo Miskovec, ele fez uma aula pré-gravada que vai ser compartilhada com vocês e ele não se encontra atualmente em Londres, ele se encontra em viagem, visitando os pais dele no interior da Sérvia. Ele vai entrar mais tarde para a participação da discussão. Então vamos com a aula do professor Danilo Miskovec sobre a abordagem bottom-to-up no câncer de cólon direito.
Before I talk about the technique, I just want to make some notes about CME and why we are doing it the way we are doing it. So, first of all, the definition of CME. Our definition of CME really is a complete longitudinal, central, and circumferential resection of the right colon. What is important to understand, it's not just about this. It's not just about the central vascular dissection. Although this is an important step, it's not the only step that is important. So we have to see the CME as really a surgical concept based on marginal gains through meticulous and standardized operative techniques. And I will show you later what that standard is in our hands. So why are we doing this? And I want to make a side note here, and that's the Mandarin problem, and I will come back to that so you will understand what I mean by that. So the first ones that really showed on a larger scale the benefits of CME were Anders Bertelsen and Danish group, and they were basically comparing their disease-free survival outcomes from their hospital where they had a standardized CME approach with neighboring hospitals where they didn't have the same standardized approach. And they could demonstrate that they had better disease-free survival in a matched group of patients. So the question is, were they actually comparing apples with oranges? So possible that there were two different patient populations, that they were not exactly the same. This was not the randomized control trial, and therefore they found differences. But it could also be that the apples and oranges were really two different operations, and they were comparing two fundamentally different concepts of surgery. And that's why they could show this difference. And the difference is quite mind-staggering. They could basically show a difference in all different stages and sometimes really quite significant. So stage 3, an absolute risk reduction of metastasis or recurrence of 17%. Now, more recently, the German group has also tried to reproduce this, and they have basically compared CME versus non-CME surgery based on the operative report of the surgeon, and they could not really demonstrate that much of a difference. They failed to actually show an overall survival difference, but they could show a disease-free survival difference for stage 3 and the trend in overall survival as well. So what was the problem? The problem was that they were comparing CME surgery, which they defined as exposing the SMV, versus non-CME surgery, which they defined as the SMV has not been exposed. So that's actually two very similar operations potentially compared. And how similar they were is demonstrated by the lymph node yield. You can see that even in the non-CME group, they had a really high lymph node yield, indicating that they also probably performed quite radical surgery. And very similar, the more recent Chinese trial showed something very similar. They were again comparing CME versus non-CME, and they couldn't really show an overall difference between the two techniques when they looked at all the stages. They could demonstrate some differences for younger patients, for stage 3, and for N2, so advanced nodal positive disease. But again, what they were looking at is basically these two techniques, taking out the right colon by exposing the SMV versus taking out the mesentery almost in a similar way, but not exposing the SMV. So both, again, very similar and radical operations. So were they still comparing apples with oranges, or is it possible that they were potentially comparing oranges with mandarins? Both fruit come from China. Both look very similar, and both taste very similar. And that, ladies and gentlemen, is the Mandarin problem. Are we comparing oranges with mandarins, oranges with apples, mandarins with tangerines, tangerines with apples, or apples with pears? We don't know. And that's why it makes it so difficult to understand these data. Well, until then, we decided that we will offer CME to all the patients until we understand better what this data means. And what it really means, and that's what it's really about. It's not about where exactly on the vessel you are, what exactly you're doing there. What is really important is that you have a standardized radical approach, do anatomy-guided surgery and clean surgery to remove that part of the colon with its associated mesentery. And I show you now our standardized approach. And how we do it, and again, I explain a little bit the rationale behind that as well, why we are choosing the approach that we do. We do these operations robotically, so this is our standard theater setup that actually doesn't matter whether it's right or left or rectum or anything else. We always use the same approach. We have the robot on the left side of the patient. We have, and in this test, obviously, we have the vision card, some additional screens. We have a nurse on the right side of the patient. We have an assistant between the legs of the patient, where you actually, for a bottom-up approach, they can assist quite nicely if necessary. And we have 2 surgeons on the consoles. This theater setup is important because everybody can see what we're doing and we can all communicate with each other. And that creates this kind of human bubble on one side of the patient versus the machine side on the other side of the patient. We then dock the robot from the left, and we can use the bottom-up approach. And here is the port setup for that. We always start with an Alexis port. So we do a fun and steel incision, put in an Alexis port, and through that port, we insert a 12mm robotic port that will serve us as an assistant port and later also for stapling, as I will show you. We then identify the anterior superior spine on both sides. We draw a horizontal line between the 2 bony structures. And across that line, we distribute 4 8mm robotic ports. We then dock the robot and use the instruments in this way. I always use 2 right hands, so the camera will be consequently will be on the in port 2. On the left side, a grasping instrument. On the right side, usually scissors, and on the furthest on the right side, another pair of grasping forceps. When it comes to stapling, we just simply move arm 3 from the 8mm port to the 12mm port in the Alexis. And we can insert the stapler through that and do the intracorporeal anastomosis and resection, etc. That just saves us from having an additional 12 port. More importantly, with this approach, we basically have a clear view, and you will see that in the video later, of the central vascular compartment, because operatively, this is the most challenging thing to do, and we can see clearly onto that. We always use this open book model in terms of how we see the anatomy. So you will see in the video, we will start below the ileocolic page. So we lift that up. We go straight onto the duodenum, onto the pancreas, and create a space behind the mesocolon. Then we will flip that ileocolic page down. We will go straight onto the vessels, meaning straight onto the SMV. We don't go to the ileocolic because we don't want to interfere with potential tumor deposits along there. And then we will take all the vessels according to our plan. At the end, we will bring the transverse mesocolic page down, and we will enter the plane between the stomach and the transverse colon, and then do the hepatic flexure and lateral release. And finally, we will do the intracorporeal anastomosis. And here we go with the video. I'm just starting it. We are seeing now the bottom-up approach. So we're looking from below the ileocolic mesentery onto the duodenum. We are dissecting straight onto the duodenum, and that will lead us onto the surface of the uncinate process of the pancreas. We can open up that whole space until we see some veins appearing here, and that's when we usually stop, and we can put in a swab for now, and we will address that later. We are bringing the patient now into a more head-up position, meaning that we are putting them also into a side tilt, and we can move away the whole small bowel. We have now a perfect view from below onto the mesentery and straight onto the central vessels, which are straight in the middle. We can identify the ileocolic fairly easily by just pulling a little bit on the ileocolic transition, and we can see where about the superior mesenteric vein and artery will lie. We open up that area, that peritoneum, and we kind of dig deeper until we reach the vein, and we go straight onto the vein to really have a close dissection on the vein surface. And we open up that, we can dissect the vein open and identify the vessels. We're starting here with the ileocolic vein. You can see the vein very clearly here coming off the SMV. We are dissecting around it using our scissors. And once we have a 360 clearance, we can put on some clips. We're using these hemolocks and then transect the vein. In this patient, we will find the artery right behind it, which is undercrossing the SMV. And again, we put some clips on the ileocolic artery and transect it. We can now break through into the plane that we have created earlier by opening up that space that is in front of the pancreas. You can see our swab there that we put earlier, and we can now simply just resect the mesentery away from the superior mesenteric vein, from the lateral and posterior borders. At this point, I usually go for the middle colic artery. You can see here a transition between the small bowel and the transverse mesocolic, transverse colon, mesocolon. And in that space, we will usually find the middle colic artery. It comes up here, and you can see a bifurcation of the right and left main branch. For this patient, we're only going to take the right branch. I'm just testing here with ICG as well, the perfusion of the transverse colon by closing the right branch, the one that we want to take. And you can see there's plenty of blood flow going into that part. Now, this is the gastrocolic trunk of Henle. So here we see a pancreatic, a colic, and a middle colic vein. We're taking the right colic vein and the right branch of the middle colic vein, which is going into that branch as well. And we can basically dissect them. And then you can see behind the gastroepiploic vein that is going up to the stomach. You can see we can open up here a bit more, and that's basically all the vessels done. At this point, I usually then just go straight up through the transverse colon mesentery to the transverse colon where I want to transect it, and I take the colon at this point with a stapler. So I have this whole part here basically finalized. I'm now going above the mesocolic page, and we go between the gallbladder and the duodenum, and basically go back into our plane. You can see the same swab again that we saw earlier that is lying on the pancreas, and we can then open up the whole hepatic flexure. And now we just have to simply transect between the transverse colon and that plane that we've created behind the gallbladder, and we can now remove that part of the specimen completely. So the only things now, you can see here just an overview of the vessels, the gastroepiploic vein. We have clipped the right colic and the middle colic veins from the trunk of Henle. We can see the middle colic artery with the right branch taken. And then further down, we can see the ileocolic vessels. Once the specimen is completely removed, we basically create an intracorporeal anastomosis. It's usually an isoperistaltic side-to-side anastomosis, and we close the defect with a V-lock suture. And that's basically the whole thing done. We remove the specimen through the funnel steel. We're looking upside down now onto the funnel steel, and we can just hand out the specimen to the assistant who will remove it. So this is the bottom-up technique. I hope that was useful, and thank you very much again for having me.
Aula espetacular. Tivemos a oportunidade de ver, então, evidências científicas a respeito da incisão total do mesocólon e secção linfonodal central, com uma aula de anatomia e de técnica cirúrgica como poucas antes vistas. Muito obrigado, professor Danilo Miskovic. Espero que possamos contar com a sua participação no debate logo mais. Vamos seguir agora com a nossa segunda aula, que será proferida pelo professor Leonardo de Castro Durães, que nos fala atualmente de São Francisco, né? Embora o Leonardo, como já é conhecido de todos, ele seja um Associate Staff Colorectal Surgeon da Cleveland Clinic de Ohio. Ele se encontra hoje em São Francisco para um outro evento e gentilmente aceitou o nosso convite. Já é a segunda vez que o Léo participa do nosso simpósio de cirurgia robótica coloretal do Hospital Moinhos de Vento. Léo, muito obrigado pela tua participação. Eu sei que aí tu está com uma diferença de fuso horário de, acho que 3 ou 4 horas, portanto deve estar na madrugada no hotel. Muito obrigado mesmo. Leonardo vai falar para a gente a respeito da abordagem medial-lateral na colectomia direita robótica. Léo, the floor is yours.
Thiago, muito obrigado de novo pelo convite, é sempre um prazer. E realmente tem uma diferença de fuso horário aqui, estou no Congresso do Colégio Americano de Cirurgia. É um prazer, mesmo estando aqui 5 horas da manhã, é um prazer estar com vocês aí. Vou tentar... Vocês estão me escutando bem?
Estamos.
Espera aí. Ok. Está vendo a tela?
Sim, conseguimos vê-la.
Ok. Então, vou falar um pouco da abordagem medial lateral, que é a abordagem que a gente realiza mais frequentemente na Cleveland Clinic. E vou explicar, na verdade, até o porquê que a gente realiza essa abordagem. Então, não tem conflito de interesse. Então, a gente sabe que, levando um pouquinho da história, o câncer coloretal, o câncer de colo direito, né, foi sempre feito com cirurgia aberta. Em 2004 foi quando começou, na verdade, o estudo COST saiu, e logo em seguida o estudo Color, que mostrou que a cirurgia laparoscópica podia ser utilizada para o câncer de cólon sem ter aumento de recidiva introcáter. E, mais recentemente, né, tem a cirurgia robótica, que está ajudando, assim, uma próxima etapa, principalmente quando a gente tem que fazer procedimentos mais finos, né, como a excisão completa do mesocólon. Eu não sei se vocês conhecem o Dr. Turnbull. Ele foi o primeiro chairman da Cleveland Clinic, da coloproctologia. Ele foi o chairman até 1976, e ele publicou, naquela época, mais de 180 artigos. E uma coisa que ele olhou, ele fazia uma técnica um pouco diferente na época. Você tinha uma técnica convencional, e que, quando tinha um tumor de cólon, existia a abordagem lateral para medial, e, como vocês podem ver aqui, a espécime, como termina, né, na abordagem terminal para lateral para medial. E ele criou uma técnica chamada non-touch technique, que a ideia seria você tocar no tumor no final da cirurgia, para evitar a disseminação tumoral. Então, ele começava nas veias, né, nas veias, artérias centrais, no caso da colectomia direita na ileocólica, e, a partir daí, você dissecava por baixo do tumor, no reto peritônio, e depois você abordava o tumor, quando o tumor já estava isolado. E ele provou, na época, que essa cirurgia dele, né, que é a cirurgia da forma que ele fazia, porque os pacientes, na época, a classificação era DUC-C, tinha uma sobrevida muito melhor do que os colegas, a cirurgia que os colegas realizaram. Quando começou, na verdade, a cirurgia laparoscópica, todo mundo começou da lateral para medial, né, porque é a forma que fazia na cirurgia aberta. Como na Cleveland Clinic fazia medial para lateral, o Dr. Milson, na época, quer dizer, em 95, mais ou menos, 93, 94, ele começou a fazer estudos para fazer a técnica do Turnbull, que é a técnica medial para lateral, né, que tentando fazer em laparoscopia a non-touch technique. E com isso, né, depois que ele fez os estudos e padronizou a técnica, ele basicamente disseminou a técnica para o mundo inteiro. Então, quando você vê um estudo aqui, por exemplo, eu peguei um estudo aqui que mostra, comparando medial para lateral com medial, você vê que a abordagem medial para lateral, você tem uma quantidade maior de linfonodos, né, do que a lateral para medial. E, de novo, um outro estudo mostra que não tem, né, diferença em questão de morbidade, mortalidade. Na verdade, não teve muita diferença. Os estudos não mostram, atualmente, muita diferença na sobrevida. Mas foi a forma, né, que foi padronizada na Cleveland Clinic e padronizada para o mundo. E como já foi falado, né, a próxima etapa seria a excisão completa do mesocolo, né, que é a excisão D3, que acabou de ser apresentada, né, muito, muito bem, e que a vantagem da cirurgia robótica é que você realmente consegue fazer essa dissecção mais fácil. Né? E eu já, no caso, né, uma meta-análise da excisão completa do mesocolo mostra que tem uma sobrevida um pouco melhor do que quando não se realiza a excisão completa do mesocolo. Então, eu vou mostrar umas fotos aqui, elas a princípio são da laparoscopia, mas basicamente laparoscopia e robótica, né? A técnica é semelhante, a gente não muda muito. A posição na mesa cirúrgica é uma posição de litotomia. Na cirurgia robótica, a gente coloca o trocado um pouquinho diferente do que foi apresentado na palestra anterior. A gente coloca o trocado na diagonal, como se fosse, pensando na colectomia esquerda, a gente usaria também a mesma direção, só que a direita do umbigo, e na colectomia direita, a gente vai vou colocar esse trocado também na diagonal, mais para a esquerda. A primeira etapa da nossa cirurgia é preparar o campo cirúrgico, né, que é realmente pegar o aumento e passar o aumento para cima do cólon transverso. E a gente começa a cirurgia nos vasos ileocólicos. Então, a gente faz uma tensão na artéria e na veia ileocólica, e né, levando aquela consideração, né, do Turnbull, a gente começa nos vasos para isolar o tumor de qualquer tipo de disseminação. A gente cria uma janela embaixo das veias ileocólicas, e na verdade é muito fácil de você conseguir ver as veias ileocólicas. Se você pegar o seco e subir com o seco, ou pegar as veias diretas, você consegue facilmente entrar nesse plano, e esse plano você consegue ir dissecando ele, né, em cima no reto peritônio, vendo o duodeno, né, ali à direita, no fundo, você vai dissecando o duodeno para baixo. E a gente, depois disso, né, você vai ligar os vasos ileocólicos. Depois você tem a dissecção do mesocolo, do duodeno e do pâncreas, e vai ligar a artéria direita da cólica média, o ramo direito da artéria cólica média. A partir do momento que está todo o tumor, né, assim, as partes arterial está dissecada e controlada, a gente vai entrar no pequeno aumento, né, fazer a mobilização da flexura hepática, e aí a gente vai dissecar de lateral para medial, encontrando o plano de dissecção anterior. Né, primeiramente no seco, e depois no colo ascendente. E terminando na flexura hepática, quando vai terminar a nossa dissecção. A partir desse momento, a gente realiza, então, retira a peça cirúrgica e faz a anastomose, que nós vamos mostrar aqui no vídeo. Esse vídeo eu queria agradecer ao Henry Gordon, ele apresentou aqui no congresso, nesse congresso 2 anos atrás, e ele cedeu esse vídeo que eu achei muito interessante, porque você vai ver, na verdade, a gente vê a vantagem do robô, porque o tumor, ele está invadindo o duodeno. Então, aqui você prepara o campo cirúrgico, e você vê ali uma invasão duodenal, né, do tumor. Então, resolvemos fazer a excisão completa do mesocolo. Você começa, então, embaixo da artéria, né, da ileocólica, igual eu expliquei. Vai seguindo ao lado da veia mesentérica superior, ligando a veia e a artéria. Nesse caso, tinha um ramo direito da cólica, a cólica direita. E, por último, né, liga o ramo direito da cólica média. E, como você olha ali na hora que o duodeno está dissecado, você vê que o tumor está invadindo o duodeno. Normalmente, quer dizer, em laparoscopia e tal, a tendência seria você converter, mas no robô, você pode realmente fazer a dissecção e tirar a parte do duodeno que está invadindo. Né, o ramo direito. Depois a gente faz a dissecção lateral para medial. E tá aí o duodeno aberto. O robô você pode fazer uma sutura de forma fácil. Então, fechando o duodeno. Né, após retirar da peça cirúrgica. E, de novo, assim, o robô permite realmente um avanço, né? A gente pode fazer algo mais que em questão da laparoscopia a gente não conseguiria. Então, igual foi explicado anteriormente, você liga o cólon, liga o intestino delgado e a gente faz a anastomose, usa o Firefly para confirmar realmente a vascularização e faz a anastomose lateral, de preferência isoperistáltica, às vezes anisoperistáltica. E depois a gente fecha onde o stapler entrou. Com a sutura. Então tá aí a peça, né, com o duodeno incluído e a excisão completa do mesocólon e as posições trocadas, uma fenestil foi aberta nesse paciente. Ok, muito obrigado. E agradeço de novo a oportunidade.
Léo, perfeito, muito obrigado. Interessante, trouxe um pouco da história da cirurgia robótica, da cirurgia colorretal, né, com o Turnbull, apresentou as evidências, demonstrou essas fotografias e no final um vídeo magnífico de uma ressecção duodenal tangencial conjunta com uma colectomia direita com a abordagem médio-lateral, que é a abordagem que nós aqui no Hospital Moinhos de Vento fazemos de rotina e que é a abordagem que eu acredito que a maior parte dos cirurgiões robóticos coloretais adote atualmente. Eu tenho algumas perguntas, mas obviamente isso a gente vai discutir na sequência. Muito obrigado. Vamos então dar seguimento para a terceira aula deste módulo de câncer de cólon direito. Quem vai falar para a gente agora é o Dr. Carlos Ramon Mendes, também conhecido de todos nós, cirurgião de extrema habilidade, amigo que já participou de outras edições desse nosso simpósio. Ramon, muito obrigado. Ramon também não está em casa hoje, da mesma forma que o Léo estava em São Francisco, o Ramon está, acho que no Recife, se eu não me engano, participando de outro evento. Então, Ramon, obrigado aí pelo sacrifício. E o Ramon é o chefe do serviço de coloproctologia do Hospital Santa Isabel, né? Coordenador do núcleo de coloproctologia do Instituto Baiano de Cirurgia Robótica. Eu dei para o Ramon certamente a tarefa mais ingrata desse nosso simpósio, que é de falar de uma abordagem que não é aquela que ele faz habitualmente, né? Caberá ao Ramon falar para todos nós a respeito da abordagem lateral medial. Ramon, muito obrigado. Deixo a palavra contigo aí.
Thiago, obrigado pela oportunidade de estar com vocês aí. Acho que para mim é um prazer enorme poder participar desse evento. É um evento que já ganhou uma forma bem grande aí, com grandes palestrantes. E realmente, assim, a minha função é falar algo do que não é nossa rotina, tá? Mas eu procurei deixar de uma forma bem clara, assim, e tentar ajudar todos, mostrando a abordagem lateral como uma abordagem alternativa. Eu não consigo compartilhar minha aula com vocês aqui, mas eu gravei agora cedo, agora já gravei ela e já enviei. Se puder rodar minha aula aí, e depois a gente passa para discussões.
Olá, amigos. Bom dia a todos. Tivemos um problema técnico aqui, não conseguimos compartilhar a minha tela da aula com vocês, mas eu vou apresentar para vocês aqui e vou estar online durante a discussão, tá? Então, como eu vim falar um pouquinho sobre o câncer de colo direito, a abordagem lateral medial, mas eu vou focar um pouquinho nessa abordagem de lateral medial no tratamento, na cirurgia robótica. Um dos pontos mais importantes na cirurgia é sempre você definir o seu setup. Isso principalmente quando você usa o robô SI e o robô X, porque vai depender da posição do paciente, a posição do robô, diferente do robô XI, que não tem tanto esses detalhes. Um dos detalhes que eu gosto de fazer na toda a colectomia direita, eu gosto de fazer um pouquinho dessa elevaçãozinha, esse pilé um pouquinho no dorso do paciente. Com isso eu consigo ampliar mais um pouco esse abdômen e com isso eu distancio a posição dos trocáteres e diminuo a chance de choque dos braços robóticos, tá? Então, um dos que a gente usa nas colectomias direita. Quando você vai docar com o robô SI ou X e uma lesão de seco, geralmente o dock que a gente usa, se for o SI, é essa posição 3, 1, câmara ou 2, ou no braço do X, é 1, 2, 3 e 4. Tá? Então, esse é o dock que a gente usa quando vai trabalhar na região do seco. Se vai trabalhar ali naquela região do ângulo hepático, com a colectomia direita, com a linfaectomia, com a D3, esse é o dock que preferimos usar, usando o robô X ou SI. No robô XI, torna muito mais fácil, o dock é muito mais simples, é mais fácil de ser feito. E aí sim, eles traçam a linha em diagonal, pegando ali a linha M clavicular esquerda e descendo um pouquinho ali depois da linha média à direita. Então esse é o dock com o XI, é muito mais fácil, mais simples fazer esse dock. E da auto não vou falar sobre esse dock porque já vamos ter uma aula sobre essa abordagem. Então, o mais importante na cirurgia é você ter alternativas, tá? Então, assim, existe uma padronização. Eu prefiro fazer sempre minha cirurgia de baixo para cima, da auto-up. Eu prefiro minha cirurgia, na maioria das vezes, de medial para lateral. Ou a minha preferência é lateral para medial. Então, o mais importante na cirurgia é você ter as alternativas, as opções para você poder modificar a sua abordagem, tá? E muitas vezes o que acontece? Tem aquelas situações mais complexas. Então, na doença inflamatória intestinal, você tem aquela massa, aquele bolo ali na pelve, tudo aderido, colado. Então, assim, uma das vezes você pode fazer essa mobilização lateral. Isso você pode fazer com o robô para poder depois você atacar o meso, tá? Então, a abordagem sempre, a opção de você usar essa abordagem lateral. Então, sempre a vantagem dessa abordagem lateral é isso, é você poder isolar toda aquela região e aí sim atacar o meso. Imagine você entrar aqui, fazer uma colectomia direita robótica, já atacando essa região aqui do meso. Então, isso torna-se extremamente difícil, porque isso aqui está tudo, a massa é um bolo, você vê que as alças aqui grudadas, então é muito mais complexo. Então, eu vou começar na robótica, eu faço sempre, nessas situações de doença inflamatória, a preferência é isso, é você fazer essa abordagem lateral para depois medial, tá? Isso que é o mais importante. Então, você ter uma alternativa de abordagem, você poder ter outras formas de abordar. Outra situação que você também pode optar pela abordagem de lateral para medial. Então, você vê muitas vezes a endometriose. Eu não preciso fazer aquela colectomia extensa, eu não preciso ligar a ileocólica na origem. Então, eu posso mobilizar todo o colo direito, soltar o colo direito, para depois eu fazer essa abordagem onde está a lesão, no ilho e no seco. Então, isso é extremamente importante, você poder ter essas opções, essas alternativas de abordagem, tá? E aí sim, eu falo que a abordagem lateral para medial, ela se torna bastante importante nesses casos que a gente pode realizar nesses pacientes. Então, ter isso como alternativa, ter isso como opção de fazer essas abordagens é bastante segura e me dá bastante conforto para realizar os procedimentos. Algumas situações também você pode soltar toda ali a lateral, então você fez toda a liberação lateral ali, você vai mobilizando esse colo direito, então para depois sim você atacar a parte mais medial, tá? Então isso é um truque, então você, aqui No vídeo eu estou mobilizando todo o lado, todo o colo direito, tá? Então, tá vendo aqui a válvula iliocecal está aqui. Eu estou liberando aqui um pouquinho de baixo para cima, mas liberando toda essa goteira lateral aqui, soltando todo isso aqui para depois, sim, eu atacar esse meso, onde está tudo embolado, tudo grudado, torna mais complexo essa abordagem nessa região. Então, é uma opção, sim, você poder fazer essa abordagem lateral, para depois você vir e atacar os vasos aqui principais, tá? Então, é sempre ter essas alternativas cirúrgicas, de opções cirúrgicas, é importante para o cirurgião, porque nas situações mais adversas é quando ele vai poder usar essas abordagens aí mais complexas, tá? Então, aqui já não vou mostrar o vídeo de anastomose, isso aí você já sabe, mas a questão nossa é mais discutir essa abordagem de lateral para medial. E muitas vezes também tem aqueles pacientes gordos, paciente obeso, que tem bastante dificuldade, tá? Então, é uma opção também. É isso, é você fazer toda essa mobilização do ângulo. Aqui estou mostrando um pouco de vídeo de cirurgias por vídeo, na verdade, mas é só o principal é mostrar a opção de abordagem lateral para medial. Você sempre tem que ter ela em mão para depois você não passar nenhum aperto cirúrgico, né? Então você vê que está todo o colo mobilizado e por fim, eu vou atacar a iliocólica na minha abordagem cirúrgica, tá? E aqui um vídeo mais completo, um pouquinho dessa abordagem. Então aqui é um paciente com várias aderências, tá? Então eu vou primeiro soltar essa aderência, mobilizar para poder conseguir mobilizar o colo transverso, jogar o colo transverso para cima, ter mais espaço. Então seria um paciente obeso, então é um paciente que dá bastante trabalho para você atacar o meso nesses pacientes. E aí, nesse caso, a gente optou por essa abordagem lateral para medial, tá? Então você vê que vai devagarzinho, primeiro soltando todo esse processo aderencial, tá? O grande aumento, grudado. Mas a grande vantagem do robô é isso, essa precisão. Você vai devagarzinho ali, soltando essas aderências. O paciente tinha uma cicatriz prévia na minha média, então você vai soltando tudo isso com segurança. Você tem um monopolar na mão, você tem um bipolar na outra mão, e você vai aos poucos soltando todo esse colo aí, liberando ele. Então isso facilita bastante na hora da abordagem, tá? Então, fez toda a liberação, eu vou começar a tirar esse tecido de gordura. Então começa a aparecer ali o fígado, onde eu vou poder jogar meu colo transverso ali em cima para repousar naquela região. Começa a aparecer ali para mim essa visão. E aí sim, agora eu vou para essa abordagem lateral. Você vê que tem bastante alça e delgado, paciente obeso, então bastante trabalho abordar essa parte aí mais medial, do colo transverso caindo sobre, eu não tenho espaço, não tenho como operar ali. Então a opção nossa realmente vai ser essa abordagem aí de lateral para medial. Você viu que estava bastante embolado ali, as estruturas todas emboladas, então eu já falei toda essa liberação lateral para a gente poder mobilizar mais o colo e aí sim a gente poder conseguir atacar os vasos iliocólicos. Então, acho que o mais importante é isso, é você saber abordar, saber quando usar. Não vou dizer que é para fazer todos os casos a abordagem fazer de lateral para medial, mas você tem em mente isso aí. E você vai ver como vai facilitando, os planos vão aparecendo para você, as estruturas vão se mostrando melhor, porque realmente o paciente obeso é bastante complicado, tá? Então aí, liberando todo o colo direito, a gerota aí, preparando o colo direito. Então essa é uma tática de abordagem cirúrgica que ajuda bastante o cirurgião, tá? Então você vê que fazer a cirurgia com o robô facilita e facilita muito, nos ajuda nessa abordagem. E vai sempre aos pouquinhos, caminhando aos pouquinhos aí para poder fazer essa dissecção, tá? Se você tem uma pinça de energia, isso facilita mais ainda a fabricação desse tecido de gordura, principalmente paciente obeso. Então, aqui fazendo a liberação do ligamento gastrocólico ali, já indo para o ângulo hepático do colo. Então, essas pinças de energia realmente ajudam bastante nessa dissecção, nessa abordagem aí desses espaços, né? Então, você vê, o colo vai caindo todo para a esquerda. Então, você vê, o paciente obeso, você vê, a cirurgia é difícil, trabalhosa, complexa, mas aos pouquinhos você vai ganhando, né? A gente brinca como se fosse comendo sopa pelas beiradas. Então, você vai ganhando esse espaço aos pouquinhos, mexendo, ganhando um pouquinho mais. E, por fim, quando você vai chegar agora no meso, olha que diferença a apresentação do meso desse paciente. Então, eu consigo ver aqui o duodeno, já consigo ter uma visão melhor, uma apresentação melhor desse paciente. E aí sim eu poder acessar para ligar a mesentérica, a ileocólica desse paciente. Então, uma coisa que no começo da cirurgia eu não conseguia ver essa abordagem, mas agora eu consigo ver com maior perfeição. O robô vai me apresentando melhor essas regiões e eu consigo ver com mais clareza essa região. E aí, por fim, a ligadura dos vasos ileocólicos e terminando com a secção e anastomose lateral isoperistáltica. Então, de mensagem que eu quero deixar vocês, a abordagem lateral para medial ela é uma alternativa cirúrgica, é muito ideal para aqueles pacientes obesos, pacientes que têm doença inflamatória intestinal e pacientes com endometriose. Muito obrigado.
Nós que agradecemos, Ramon, por ter atendido esse nosso desafio e te desvencilhado tão brilhantemente dessa tarefa difícil que a gente deu. Depois o Ramon até pode comentar, aproveitando, né, Ramon, que agora, logo mais em novembro, a gente vai ter a terceira edição do Robotic Surgery Experience, que o Ramon também é um dos organizadores. Pode fazer o teu jabá e acho que seria importante para todos nós. Tá?
No dia 22 e 23 de novembro em Salvador, nós temos um evento nosso aqui de cirurgia robótica, onde vai ter abordagem tanto da parte colorretal, urológica, cirurgia geral, pediátrica, tórax. Então são 2 dias de imersão em cirurgia robótica, onde a gente conseguiu convidar os maiores, os experts aqui do Brasil e alguns de fora também, para estar conosco nesse evento. Então, quem puder comparecer, vai ser um prazer encontrar vocês aqui em Salvador, no dia 22 e 23 de novembro.
Maravilha. Bom, então nós tivemos a oportunidade de assistir 3 aulas abordando a mesma doença, né, o câncer de cólon direito, mas com 3 visões diferentes. Né? Abordagem de baixo para cima, abordagem medial para lateral e lateral para medial. E obviamente que esses assuntos suscitaram uma série de dúvidas e eu gostaria então de passar para a nossa sessão de discussão, que está prevista para durar aí em torno de 36 minutos, até às 10 da manhã. E para essa discussão, eu gostaria de apresentar os nossos debatedores, tá? Inicialmente, eu vou apresentar o Dr. Bruno Augusto Alves Martins, do Distrito Federal. O Bruno é membro do Serviço de Coloproctologia do Hospital Universitário de Brasília, preceptor do Programa de Residência Médica em Coloproctologia do Hospital Universitário de Brasília, e ele é Honorary Clinical Observer do St. Mark's Hospital e Academic Institute, Londres, Reino Unido. Além de um grande amigo nosso já de alguns anos. O segundo debatedor será o Dr. Timothy John Wilson, coloproctologista do Hospital Moinhos de Vento e diretor clínico desse nosso hospital. Nosso terceiro debatedor será o Dr. Kleber Além Nunes, coloproctologista do Hospital Moinhos de Vento e nosso colega de equipe. E, por fim, o Dr. Renato Gomes Campanati, professor adjunto do Departamento de Cirurgia da Faculdade de Medicina da Universidade Federal de Minas Gerais. Eu agradeço a todos vocês pela participação e declaro aberta a nossa mesa redonda para discussão. Eu não sei se o nosso convidado internacional, o professor Danilo, conseguiu entrar, mas vamos dar continuidade. Eu vou pedir inicialmente para o Bruno começar nessa sessão fazendo suas perguntas. E Professor Danilo Miskovic, good morning.
Good morning.
It's a pleasure
Hello.
to have you here with us.
Hi.
I
Sorry,
can
I'm,
see you are.
Yes, I am at the moment in Serbia, but I'm very happy to join from here if that's okay.
It's a privilege for us to have you here with us. You are climbing a mountain. What are you doing right now?
Yes, I show you. We are having a meeting with the Serbian Society of Color Proctology, and we are climbing mountains at the moment.
Fantastic. Well, your presentation, your pre-recorded presentation were fantastic. It was amazing, your video, and thank you very much for sharing your experience with us from Brazil. Well, so let's start with Bruno, and then we can move to Professor Timothy, Kleber, and Renato. Bruno.
Good morning, everyone. Thiago, would like to express my gratitude for your invitation to this high-level scientific meeting. I'm going to start with the discussion with a question for Mr. Miskovic. It's great to see you again, Mr. Miskovic. We know that the vascular anatomy of the right colon is highly variable. Do you think we should routinely use vascular reconstructive models in the preoperative planning of CME? And also, the preoperative CT scan is different from the traditional staging CT that we do?
Yeah, so thank you for the question. I think ideally, yes, we would. The problem is that the technology doesn't keep up yet in terms of that we can easily create these models, probably reconstruct things, but then it's quite difficult to make sense of it. So we use normal staging CT scans for that, but we have the limitation that the contrast is sometimes not good enough to make the 3D models automatically. So we kind of try to do them more or less manually, but it's not a process that happens automatically. And I think that's the main hurdle at the moment. If we could just create them very easily automatically, yes, then it would be perfect to have them for every case.
Thank you, sir.
Dr. Timothy?
In the first place, I'd like to thank Thiago for the invitation to be part of this panel, and especially to thank our guest speakers for being part of our meeting. It's a great privilege to have you, and the presentations were really fantastic. I had a question too for Professor Danilo. I saw your presentation. The dissection was exceptional anatomy. I would just ask you if you, in any case, use an energy device in a more obese patient with a shorter mesocolon. Find it useful to use an energy device. If I may, to another technical point, great fear is bleeding in and around the FB. Do you ever use any of those hemostatic topical agents for smaller bleeding around the fat in and around the pancreatic plane? Thank you, Dr. Danilo.
Yeah, so we do sometimes use energy instruments, especially in obese patients, because it's just easier to get through a lot of fatty tissue. So with a robot, we use a synchroseal or a vessel sealer. But generally, I try to operate with scissors only. That's one reason for that is for cost reasons, but also for the fact that we can do usually a cleaner and more anatomical dissection with scissors rather than with energy instruments. The other question, if I understood correctly, was whether we use any topical agents to stop bleeding on the pancreas or on the fat. Is that correct?
That's it. That's it. Those topical agents like fibrin, glufibrin patch, or powder.
So I usually use a hemostatic patch. So we use Veriset without. I'm not trying to make any advertising for that company, but that's the favorite product that we use. And I also use that in case we have small injuries to the central vessels, so to the SMV, especially to the vein. I would recommend not to try and stitch these vessels, or to try and do some sort of reconstruction with sutures, because that usually makes things worse. These veins are very delicate and very small. And so something like Veriset, I'm sure there are other products that are doing the same thing, is actually much more effective. And then often also, it's just about pressure. So we just put a swab on, we leave it for 2-3, and then often it stops on its own, because all these vessels are very small generally. These are not major vessels, and most of it is venous, not arterial. And so it will just stop, provided that the coagulation works.
Thank you very much.
Dr. Kleber, please, your question.
Hi, Thiago again. Thank you for the invitation to stay in this meeting again. It's a very interesting meeting. Enjoy a lot. I will start and I'll give in the sequence the answer to Dr. Danilo. I'd like to ask you if you use routinely to do a centrovascular, a complete mesorectal excision in all of your case, or if you have any case that you do not doing this, perform this surgery, you use always the same techniques from bottom to up to do the surgery, or you use approach from medial lateral?
Thank you for the question. Yes, so this is our standard approach, the way I showed it. We do this basically for every patient with cancer. We do not select, and the reason for that is because we are not able to identify those patients yet that truly benefit from this approach. So from our data that we don't have more complications, so the morbidity is not increased by this approach, and that's why we feel, until proven otherwise, we continue with this for every patient. So it doesn't matter on the staging, because CT staging is extremely unreliable. We don't select patients that are nodal positive on CT.
Professor Danilo, your connection right now is not good. Lose Professor Danilo. Oh, he's probably in the summit. And the connection not good right there. Well, without Professor Danilo, Diego, quando ele voltar, por gentileza, me sinaliza. Vamos retomar, então, de repente, o modo português. E se ele conseguir conexão novamente, a gente retoma as perguntas para ele. Curioso que a gente tem aqui um triatleta, um alpinista. E, Léo, qual é o teu esporte aí? É câncer de colo direito e alguma atividade física? Bom, vamos passar aqui agora para o Renato. Vamos passar para o Renato, então, fazer a pergunta dele. Renato, obrigado por aceitar o convite aí.
Eu que agradeço pelo convite. Não sei se o Danilo está escutando ou não. Mas eu achei que as aulas foram excelentes. Hi, Mr. Miskovich. I wanted to know, I believe that this technique of bottom-up approach was a natural development from what you did before, like a medial approach. I don't know. Did you start doing it, the bottom-up approach, only for better vascular exposure and more safety, or do you think there are other differences, like a more intact peritoneum, an easier way to get to the root of the myelocolic vessels?
Sorry, I'm not sure if you have muted me, but I can't hear anything anymore. Can you hear me?
We can hear you.
Loud and clear.
Okay, I don't know if you heard me earlier. Did you get my response or not?
Some part of it.
Part of your response we didn't. Just the beginning of your answer.
So I'm so sorry. So what I was saying is that this is our standard approach. We always do bottom up. We don't use any other approaches unless we are forced to by adhesions or any other technical problems. And the other thing I said was that we do this for all patients. So all cancer patients basically get the same approach, because at the moment we feel that we cannot reliably select patients who will benefit more from this approach than others. And because we have data to prove that our morbidity is not higher, so in terms of leakage rate, in terms of recovery, we don't feel that there is a need to select patients. But there are some exceptions, and these exceptions are extremely morbid patients. So patients who have comorbidities, who are extremely sick or very old, and patients who are palliative. So these patients, we would not use that approach.
Great. Thank you, Professor Danilo. As all of our guests address one question for you, as we can see, you are going up in the mountain. If you want to continue your climbing and send us a picture from the summit when you get there, just to know that you are safe, we appreciate this. So if you want to continue with us, it will be a pleasure.
It's no problem. I'm Swiss, so I can climb mountains. It's not a problem for me.
Great. So Bruno, it's your turn.
Okay, I would like to change a little bit our discussion setting. And the question is for our three speakers, considering the advancements and changes in the operative technique for right colon cancer, how do you see the future of teaching and training our new surgeons? Additionally, if you could share experience with the dual console. I don't know if you use, I know that Mr. Miskovich has a dual console in at St. Mark's. So I'd like to hear his experience with this type of training, because I don't know if you have the same impression, but the feeling is that at the past, right colon was the surgery for the resident for the surgical training, and now it's like the most difficult surgery, that the most difficult operation that we are doing. So how about the training? How about the future? Thank you, guys.
Do you want me to take this again, or someone else wants to speak first? I'm happy either way.
Leo, Ramon?
The same. I mean, at Cleveland Clinic we have dual console too, so I think it's like the best way of teaching is. I mean, the fellows usually they start on bedside, and then whenever they feel comfortable on the bedside, then they start in the dual console. They do parts of the operation, and then at some point they will be doing the entire operation. I think dual console really helps, as you said.
Yes, I think the same thing, because I think the using two console is good, because the surgeon who was training, he see in 3D dimension the same of the surgeon using, and it's possible to change the principal surgery. I like to use the two console when it's possible. I think the future is the best way to train, but it's I have a high cost for using the two console. If you don't have, I think is if you see a lot of surgeon, it's possible to be a good surgeon.
Yeah, I agree as well. I mean, I think dual console is almost necessary to train appropriately. But as it was said, a dual console, a second console costs almost $500,000. It's a huge cost. And I think we need to raise this issue with the industry as well and push them to make training more accessible through the technology they provide. So I think it is an almost unreasonable cost for that. But so I think we need to push industry to kind of understand that this is integral and that every system actually should be equipped with something like this and not necessarily at an extra cost. I know this is slightly delusional, but I hope that this message will come through at some point. With regards to the right hemi, I think that it is difficult, but it doesn't mean that trainees and fellows cannot do this procedure. Those who are coming through us, they learn on this procedure as well. And like in any other procedure, we have a modular approach that we teach them parts of the procedure first, that they take over more and more. And then the aim is by the end of the 6 months that they're usually with us, that they're able to do all modules, at least for a straightforward case. So I think just doing bedside is basically pointless. It's important to understand the mechanics of the robot for a couple of weeks, but after that, I think they should ideally sit at the console, otherwise they don't learn.
There's something interesting, like just I want to share. I'm not sure how is it in other countries, but in the US, the fellow is required to have at least 40 robotic cases in order to have the certificate, 10 on bedside and 30 in the console. So that's the way it works here.
I think, as always, numbers are pointless as well, because everybody is learning at different speeds, everybody is learning at different rates, different cases have a different impact on trainees. So I think having a number of cases just is not useful, really. What we should move to is to have a more competency-based training, that we have competencies where we develop competencies for parts of the procedure and eventually for the whole procedure. One surgeon, this may take 5, for another it may take 20, and for a third one 30. So I think we can't rely on numbers as a guideline.
I think most of the panel has been involved with training other surgeons. Especially Dr. Danilo has been for many years training both on laparoscopic and on robotic colon resection. Which do you find has the smallest learning curve when you compare your teaching of surgeons for laparoscopic surgery and those that are transitioning to robotic now? Which do you find has a lesser learning curve?
I mean, it's difficult to answer because a lot of the trainees that are coming through even now have a good foundation in laparoscopic surgery. So it's a bit unfair to compare because by the time they go through robotics, they already have a considerable amount of experience. But I think in the future, we will see more and more trainees coming through that are going straight to robot. From my point of view, I think it is probably easier to learn on the robot, but I'm skewed, I'm biased because that's all I do at the moment. So I'm not entirely sure. But I think it's not necessary is that we don't need to go through stages of training in terms of doing open, then laparoscopic, and then robotic. I think this is not a hierarchy that works. In the same way, you don't have to learn to do open cholecystectomies before you do laparoscopic cholecystectomies. And the same is for laparoscopy and robotics. I think in the future, I think it's totally acceptable to go straight to robotics for trainees in the future.
Thank you.
Dr. Kleber, do you want to address a question to our guests?
The use of the energy from robotics bipolar device, do you think you can select some patients to use this, or you routinely use the scissor to perform surgery for all the speakers?
I like to use in bipolar and scissor in my surgery. Sometimes I use in advanced energy if it's possible to use, but not if patients have to pay for using the special advanced surgery. I don't use.
I personally like the vessel sealer. I use like routinely, but if you look, for example, Gorgon that I showed his video, like he does lots of robotics over there in the clinic, and he doesn't use the vessel sealage. He just go with the bipolar and scissors with a monopolar. So I think it varies a lot, but I think Gorgon basically is the only one who does it. Like I think we are like almost 20 there. Like I think everybody else there like is using like the vessel sealer routinely.
Yeah, for me, the standard instruments are as well monopolar scissors and bipolar forceps. And sometimes I do use vessel sealer or synchroseal, again, for special patients, but I prefer the other instruments because I find them more precise to detect economically.
Renato?
Specifically regarding the bottom-up approach, Mr. Miskovic, have you ever had any trouble with this trocar dispositions in, for example, slim patients, or when you have a tumor that extends up to the transverse colon and you get a difficulty in reaching the instruments?
Not with the transverse colons, actually quite the opposite, because there you have the whole transverse colon in front of you using the bottom-up approach. So you can see everything perfectly well, beyond the splenic flexure. So for that, it works actually very well. But there are situations. So you mentioned slim patients. Very short patients sometimes are a problem, and you may have to adjust the port placement slightly. So if in very narrow patients, I put my ports at the slightly oblique line, so not completely horizontal. And for very short patients, I sometimes go up a little bit more with my line so that it's not kind of too close to the bones. And sometimes you have, I think the most difficult situation is when you have adhesions into the pelvis. So on the small bowel, adhesed in the pelvis, or if you have a tumor in the cecum that is kind of stuck to the pelvic side wall backwards. So you have to even redock in the most extreme cases that you basically point the robot into the pelvis to release this first before you can do the rest of the resection.
And I totally agree with the concept of CME not being only about central vascular ligation. But other than operative standardization, do you view any other benefits of the bottom-up approach, like an intact peritoneum or a better way to access the gilo area over the pancreas, other than only the central vascular ligation?
I'm not sure, not necessarily, because I think, again, if you want to, focus on lateral mobilization, obviously it would be much better to have the ports in a more kind of oblique or even longitudinal direction. But so it is mainly about vessels, because this is the most difficult part of the operation, to get that part right. And then also, I think, to me, it just leaves you open or options. It leaves you open for options to extend resections beyond the hepatic flexure or beyond the right side into the left side if you need to. And you can see just everything in front of you. So in a way, it's almost a natural approach because you can see the whole of the abdomen in front of you. And that's the main reason why we kind of started doing this and why we're still doing it. But again, there might be situations. So, for example, I'm thinking about Crohn's resections, where the central vascular component is not relevant. It's not especially what I do, but it can be easier actually to not choose that approach, because you might want to choose a lateral to medial approach for these kind of resections, and then it's probably not the best approach. This is really for cancer.
Just on that same note where Renato was talking about the position, Do you ever have to alter the position of the table during the operation after redocking or having to do redock for all of the speakers?
I think like one of the advantages of putting the trokers in diagonal is that I think that you usually redock a little bit less. I think whenever I saw that Miskovic that he uses like a horizontal, the problem is like if the secant is too low, then you need to dock and then redock, like dock like to the bottom and then dock up. I think like whenever you do that, the way that Ramon showed and is the same way that we do here. Like I think it's better in those situations.
And then, Leonardo, in your hospital,
Right column resection. For example, if you have a tumor in the middle of the transverse column and you have to go until the splenic flexure to perform maybe a resection of the splenic flexure too. Do you think you have to change the position of the trokers for this? Because otherwise, maybe you have a collision of the arms to go the direction of the distal part of the transverse column. I'm asking this because tomorrow we'll have one case like this, and I want to hear your experience in this case.
Yeah, are you using next slide? Because like I mean the thing is like you can have some collisions for sure. I think that like I mean whenever you put on diagonal, it doesn't matter if it's left side or right side. Like whenever you go to the splenic flexure, you're gonna have some collisions. But I mean you can try to adjust the robot and just keep going. Sometimes like the one at the top close to the spleen, you just put that one a little bit lower and you do like a kind of a curve. So it's not going to be like straight. It's going to be like, not like a full diagonal, but it's going to be like curving. By doing that, you have like some access and avoid the collision on the splenic flexure.
Regarding this more distal transverse colon cancers, if you place your trokers horizontally, like that's the configuration of Mr. Miskovic, it gets really easy to operate on the transverse colon, especially if you move the table. You reverse Trendelenburg, and you can get to the root of the middle colic vessels like really nicely. One of the main problems is actually operating on the cecum, especially because you're right on top of the cecum on the right side.
Yeah, I totally agree. It's a matter of like adjusting, like where the tumor is, right? So if the tumor is more like splenic flexure, if the tumor is more like transverse, if the tumor is more like cecum, it's all a matter of like you have to adjust a little bit, you know. And then if I plan to do like just a transverse resection, or if I'm going to do like extended right or extended left, so it's you need to adjust, of course.
Thiago, can I have a last question for Dr. Ramon?
Of course, please go on.
Ramon, I think you addressed very well the indications for lateral to medial approach. I would add other indication that's when you have like a bulky nodes on the mesocolon, or a tumor that is advanced and you are concerned about the resection of the duodenum, like the case that Dr. Leonardo showed us. And other advantage, in my view, is that we reduce the traction on the vessels. So we know that when we are starting to do robotic approaches, sometimes we do we use a lot of strength to tractionate the mesocolon, and we can have some injuries to the vessels. I do ask you if, apart from this, if you have any other advice to reduce the injuries to the SMV in robotic approach?
Yes, it's a good question. I think for you reduce the trauma, it's possible to think you have to train your eyes as the principal part. If you train your eyes, you know you have a good traction or a strange traction. For me, the eyes is the best way for don't injure the vein. Another thing is you all the time you have to see the arms. If you see the arms all the times, it's the possible of you cause an injury is minimal.
Something that I think it's important, like we were talking about like 3 approaches here, but there is like one approach, at least I like a lot, which is the top button. So whenever you have like everything stuck, especially on IBD, that everything's just stuck in the pelvis, I usually start on the lesser sac. So I just put the mental knife into the lesser sac, get the hepatic flexure down, then I dissect the duodenum, like on the top-down approach, and then that's when I get to the bottom. So I think like this is a good approach that you can think about. And when you talk about the nodes, then that's when the bottom up is better. Like this one that you're talking about the nodes that you want to go. So then you go for the bottom up, and then you can get a better visualization of those nodes. So I think like Ramon said well, like in his lecture, like you need to know like not only the 3 approaches, you need to know all those 4 approaches, like lateral to medial, medial to lateral, like bottom up, top down, because like you're gonna get into situations that one is gonna be better than the other one. Of course, like the one that we prefer is to go to the vessels first, and they explain the reasons. Like then you, especially for tumors, that we want like to kind of preserve the idea of non-touch technique. But it all depends what you're able to do, like case by case.
We still have time for one more question.
And just another about the anastomosis. I see most colleagues do intracorporeal anastomosis, which is beneficial for avoiding traction on the vessels. But there was a recent publication analysis, a post-op analysis of the RELARC trial, suggesting that the extracorporeal anastomosis was related to less infection. Do you have any comments about this situation? I'd like to hear the
So basically, like it all depends on person to person, like the way the patient is. For example, like for a patient with a BMI of 20, like very thin, sometimes it's much easier for you to just do an extracorporeal. You know, I mean, it's not easier, quicker, and it's going to be kind of, I mean, you're not going to open like a big incision at all. For patients, the Cleveland Clinic regular patients, like BMI of close to 40, then like intracorporeal anastomosis helps a lot, you know, because like otherwise you have to open like a huge incision. So I think it all depends. I think maybe like you need to take a look on that study. I'm not sure which studies this, but like you know, like if they are selecting, because like at Cleveland Clinic, you kind of select the most obese patients, like sicker patients, to intracorporeal. So and then I mean the thin patients, easier ones, we end up having like an extracorporeal.
I use it all the time intracorporeal anastomosis. Only one case that I don't use intracorporeal anastomosis in patient of the obstruction, because it's not possible to section the ileum and open ileum into the abdomen. It's only way that I do extracorporeal anastomosis in obstruction.
Okay, guys, thank you very much for your participation. to dedicate your Saturday morning
Thank you
to
very
share your
much.
experience with us. It was
Very interesting.
a great opportunity for learning. Thank you very much, and we will go on with our scientific programmation with the session dedicated to left column resection, left column cancer, different strategies. For this session, we also have 2 international guests and 1 national guest. To initiate this session, I would like to invite and to introduce Professor Eloy Spin Bassani from Spain. He is professor of surgery in the Department of Surgery of University Autónoma de Barcelona, and he's the head of the unit of colorectal surgery at the University Hospital Valdebron in Barcelona. And he's also ex-president of the Spanish Association of Coloproctology and the European Society of Coloproctology. Professor Eloy has recently been here in Brazil with us in Goiânia and kindly accept our invitation to talk about different approaches for the mobilization of the splenic flexure. Thank you very much, Professor Eloy.
Thank you.
If you want, you can start sharing your presentation.
Thank you very much. First, for me, it's a privilege to be here with you, and an honor to be sharing this with all of you, and thanks again for the invitation. So, first to start, I think that it's good to point out that we have a different position of the trocars if we are going to do a splenic flexure takedown or not. The only situation that we don't do a planned not doing a splenic flexure takedown is in the APR. This is why we put the trocars in this position a little more horizontal or to the left, that with the other situations that we plan on taking down the splenic flexure. This is why we changed the middle clavicular line, which we will use for splenic flexure not taken down, to a one between the middle of the middle clavicular line and the middle laparotomy. So we call the middle clavicular line. It's where we point out to do the splenic flexure takedown. So we put the patient, and we with a really important Trendelenburg and site, and we normally do a unique target, and most of the cases it's enough, and it's the place where the left colon joins the sigmoid colon, and this is the unique target. If we have any problem in pelvis or in splenic, then we can do 2 or 3 targeting, but most of the cases we don't. Then what we first do is put the momentum up, and then we move all the small bowel to the upper right quadrant, and then we put the instruments, in which in the first arm we use the TPAP, and the second one we use the bipolar, and the third one we use the camera, and on the fourth one we normally use the scissors. We don't use the hook, but there's people that uses the hook. Why we should mobilize the splenic flexure? I think that first it's because there's an important point of the impact of not taking down the splenic flexure in some anastomotic leaks. I think it's very important, and we make it systematic, and this is why we decrease the operative time, because we are very used to taking the splenic flexure down for most of the procedures. Obviously, there are some risks. There's the risk of spleen injury or the vascular injury, but I have to tell that these are really, really, really seen very seldom in several occasions. There are 3 types of splenic flexure mobilization. It's the supramesocholic, the inframesocholic, which is the most normally used, and the lateral medial approach. I'm going to show the 3 of them. The first one is the supramesocholic. We really there's a lot of time that we haven't used. This is why I'm not using one of our videos. This is in fact a laparoscopic video, because I haven't had the chance to record one. It's, as you can see, it's you just go from supra to infra mesocolic approach. You divide the mesocolon in the middle. Sometimes it's difficult to identify where to incise this, and then you go straight to the splenic fracture, and from there you go down. This is useful in some of these patients. It's useful also when we have a lot of small bowel adhesions on the middle of the abdomen that can really make difficult to separate that and might require some extra port, and sometimes you need the change on position, because sometimes you need to take the Trendelenburg and do an anti-Trendelenburg position to make it more easy. I think it's really not very used, but I think it's good to know that and to have that in mind, just as a resource, and that if the other approaches are really difficult, the medial to lateral or the lateral to medial. Then I'm going to escape and go to the next one, which is the most commonly used, is the inframesocolic approach. Is the good thing is that we have a really dissection of the inferior mesenteric vein. It's well defined. It's very seldom that there's an anatomical alteration. The problem is that sometimes it's very difficult in very obese patients, and sometimes it can be challenging to identify the level of the medial limit of dissection. And there are some groups that have gone between the level of dissection and go into the renal veins, which is, it's not very common, but it can happen. So you have to be care on that. But the dissection of the IB, the inferior mesenteric vein, is very, I think it's very easy, and that gives you a really easy plane to go there. Sometimes it's difficult to identify the plane between the mesocolon and the pancreas, and that can be challenging. There are some videos, some of our own, and some are of our program, which is the Robótica from the European Society of Coloproctology. We start sometimes with the artery dissection and sometimes with the vein, and you can see here that the fourth arm it's pulling the mesocolon on or the left colon to the 12, and then we are using bipolar and the scissors. You can see here a diagram that you can see how we pull with the fourth arm, with the tip up. We pull the mesocolon up to 12, and with the bipolar and the scissors, we dissect the plane just below the inferior mesenteric vein, which is, as I said, it's very, very easy to manage, and from there we go all the way from medial to lateral to dissect all the left mesocolon, where we will be helped by the assistant pulling a little from the small bowel towards 6, and with the help of the TPAP lifting the mesocolon up. Sometimes we cut the inferior mesenteric on the first attempt, and sometimes we just hold that dissection of the cutting of the inferior mesenteric vein until we have already opened a deep space to the left mesocolon. Here you see that we're moving the tip up, pulling to 12, and with the help of the bipolar and the scissors, we can use it by pulling, or we can use it by pushing the lane of dissection. We will go on the dissection all the way to the mesocolon. Here we have dissected, and we are moving. We are already are dissecting on the anterior part of the pancreas. You can see here with the help of the TPAP pulling to 12, and with the help of the bipolar also pulling the transverse mesocolon to help us make the space. Here we are getting more and more deep in the dissection. You can see here the TPAP pulling the transverse mesocolon, and the bipolar also helping us with the dissection with the transverse mesocolon, or even with the posterior side of the stomach, the gastric wall, that we can enter the lesser sac space here. And if it's difficult and we don't really find this plane, we'll just leave a gaze, a swap there, and we go from above. So once we have completed this, we take the with the first arm with the TPAP, we pull the omentum up, and with the bipolar we and getting the omentum and the assistant getting the epiploic appendixes of the colon, we enter the lesser sac from above, and we will connect the plane that we had just have dissected from mesocolon with this plane of dissection, that we will try to go all the way from middle part to lateral, all the way to the splenic flexure, as far as we can. And after we get that part, we will connect that part on the splenic flexure with making the dissection from the side part of the colon. So we will make the rendezvous from side to the plane that we have already dissected here. Here we can see that the TPAP is pulling up the colon from below, and the bipolar is also helping us, and we will connect the dissection that we have done from below, from inframesocolic, from above on the omentum, and here we are just finishing the dissection of this, and we will have the entire splenic flexure down. We do this procedure in all the rectum, and I will tell you that probably in most of 90% of the sigmoid resections, we do it. Is it necessary? Sometimes probably is not, but we are a university hospital, and we try to teach all this way to our residents and fellows in order to minimize the risk of anastomotic leaks. Here's the final aspect. And then we have the final way, that's lateral to medial. We use it in very obese patients or in benign conditions. It's a friendly approach because it's the approach that it was done, or it is done in most of the cases when we do an open approach, and the position of the patient helps with the side. Sometimes might be difficult to identify the ureter, and sometimes it's more difficult with the robot because the arm movements are more exaggerated, I would say. Here you can see a case of a very obese patient that we use an endorector, and you can see that we have difficulty to get into the medial to lateral approach. This is why we decide to go from lateral to medial. We use this endorector that try to help us to get on the right medial to lateral approach, but it's very difficult. And this is why in these patients, we are doing, like you see in the right side video, that we are doing the lateral to medial approach. Here we are incising the tall fascia, and we are developing the plane. Here you can see the TPAP, it's pulling the mesocolon. The bipolar is pulling also the mesocolon, and we are trying to develop this plane. Here we will see how we have developed this plane. We are going up to the splenic flexure from lateral to medial. The arm one with the TPAP, it's helping pulling the colon, and with the bipolar, it's helping with the fine dissection that we complete with the help of the scissors. all the way up, and later we will see how we will develop the plane of dissection on the ureter. So we go all the way that we can up and then on the medial aspect also. And once we are developing this, then we move to the more inferior part. Here you're seeing how we develop that dissection, and we are just taking care of the ureter. This is the same case that I was showing you before, very obese patients, but we are developing this plane from lateral to medial. The gonadal vessels are left on the most upper part, and the TPAP will pull the mesocolon, and here we are taking care of the dissection very carefully in order to preserve the ureter all the way down. Once we have dissected this, what we do most of the cases is we leave a gauze on that part to protect the ureter, because it's very difficult from here go to the most medial part. Sometimes it's enough with this dissection. Sometimes you have to do all the dissection. So what we will do is as you can see here, we leave a gauze protecting the ureter and the gonadal vessels. And then, as we already moved all the way from up to down, the lateral to medial, then it will be more easy to complete this approach on the final part from medial to lateral, even in the most obese patients like this. We are just developing the plane now from medial to lateral, and you can see here that we are finding the gauze that we just left there protecting the ureter, and we can complete very safely the final dissection on this patient, leaving the gauze there and protecting gonadal vessels and ureter. So once we have done that, we complete the dissection, getting on a supramesocolic approach, and partial supramesocolic approach with the dissection of the omentum, and we will complete the plane that we have already dissected from lateral. So as you will see here, it's just leaving a small part of the splenic flexure. Here we give the epiploic appendix to the assistant that will pull to 6 or 7, and we will move the tip up to separate the omentum, and here we're just about to complete the dissection on this. So to conclude, the splenic flexure approach almost universal in cases of left colon resections, sigmoid resections, and rectal resections in our unit. Medium to lateral is the most used. I would say that it's about 95% of the cases. Lateral to medial, it's in obese and in benign conditions, but supramesocolic approach can be an alternative in some cases of very obese patients or with a lot of small bowel adhesions that can be difficult to do with other approaches. I just want to invite you to come to our next September 10 to 12, 2025 in the tripartite colorectal meeting in Paris that organizes the ESCP, and that you are all invited to this. Thank you very much.
Thank you very much, Professor Eloy. You, in an elegant and didactic way, show the 3 different approaches for the the splenic flexure. And I completely agree with your comments regarding the advantages and the disadvantages of all these 3 technical approaches. Well, let's move on. Later we will discuss this issue. Now I would like to call Professor Itzel Vela from Mexico. She's a colorectal surgeon from the Surgical Oncology Department of National Institute of Cancer of Mexico and Hospital Ángeles del Pedregal, and she's also the vice president of the Mexican Association of Robotic Surgery. Itzel is also a friend of many of us colorectal surgeons from Brazil, and she very kindly accepted our invitation to talk about the medial to lateral versus, or the lateral to medial approach. Sorry, I changed the title. She'll talk about the first arterial approach versus the venous first approach in left colon cancer. Itzel, thank you, and the floor is yours.
Thank you so much. I don't know if you see my screen.
Yes, we can see.
And my images also?
Yes, we can hear
okay.
You loud and clear and can see your images.
Well, buen día. Estoy muy feliz por ter sido convidada para este simposio. Dr. Tiago, I don't know if you can see this, but muito obrigado pelo meu presente. It's ótimo para mim. Muito obrigado. And I'm very happy to share this panel with Dr. Eloy Spin and also with Dr. Luis Romagnolo. So I will talk about if we should do the artery first or the vein first for left colectomy or low anterior dissection. And I will start talking about the surgical techniques. As Dr. Eloy showed before, I also put my trocars in the same position. I used the scissors. I really like the scissors. I don't use the hook neither. I use, in most of my cases, the vessel sealer, which I found it very, very useful for taking down the veins, the inferior and the artery and the vein and the artery, the inferior mesenteric vein and artery. And I use a bipolar fenestrated instrument right here. So this is when we start artery first. So I believe that at least in Mexico, this is the most common way to do it. I think this is how we learned in most of our sigmoid cases. So we start from below, we start doing the artery approach. So we are trying to find the promontory. Here we will reach out the aortic bifurcation. Then you will see here the sigmoid fossa, and we will start opening the peritoneum with the monopolar energy. So we will start doing this dissection. Our third arm is pulling up the sigmoid, and my second arm is pulling up what I believe is going to be the inferior mesenteric artery. In this approach, we will start looking first for the ureter and the gonadal vessels before taking down the inferior mesenteric artery. So with traction and contraction and with the pneumo, these planes are very easy to find. Here you will see the ureter, you will find the gonadal vessels, and we will be working in this mesocolic plane very, very easily. And after I already identify the ureter and the vessel and the gonadal vessels, then I will attack the artery. So I go in the anterior aspect of the artery. And here I think we will have to be very cautious of not injuring the nerves at this level, causing some worse functional outcomes. So at this point, at the point that I found out where is the ureter, I'm ready to take down the inferior mesenteric artery. I usually use the vessel sealer, and as you see in my second hand, I have this instrument, the bipolar, in case if I have any bleeding, I will be in control of it. And in most of the cases, a second seal is enough to control if we have any small bleeding. So now that we take down the inferior mesenteric artery, I will go up a little bit higher to reach out the origin of the inferior mesenteric vein. So at this point, most of my left colon is mobilized, at least in the lower part. So it is easier for me to go in the same plane and in the same trajectory of the inferior mesenteric vein. So I try to work a little bit higher in the mesocolic plane. Here you see the urotas fascia. I'm taking it down, and I know that I have above me the inferior mesenteric vein. So at this point, I try to go at the origin. You see here, I have the Treitz ligament, And now I decide at what level I will take down the inferior mesenteric vein. So here again, sometimes at this point it's difficult, especially if you have an obese patient, to have a proper exposure at this point of the inferior mesenteric vein. But now that I have it, I also take it down with the vessel sealer. So this is another example, another video also in the same fashion, taking down the inferior mesenteric artery, and I do the same steps, reaching out the promontory, looking out for the aortic bifurcation. Here you will see the sigmoid fossa, which will lead me to the inferior mesenteric artery, and I will work in this plane. So here I will attack the anterior aspect of the inferior mesenteric artery, use the Treitz ligament, and here in this case, before I take down the artery, I decided to go and reach for the inferior mesenteric vein and do this approach again. This is very nice when you find it and work beneath the inferior mesenteric vein. It is very, very easy to find the mesocolic plane between the urotas and the mesocolon, and then you can go up until you reach the pancreas and almost get to the splenic flexure from below. So here you see, now I have already dissected I have already referred the inferior mesenteric vein and also the inferior mesenteric artery. And at this point, I'm ready to take down the inferior mesenteric artery. So this is kind of hybrid way to do it. In this case, I haven't cut down the inferior mesenteric artery until now. And now that I cut it, again, also with the vessel sealer, I will go up a little bit higher to take down the splenic vein. So now you are free to move the whole mesocolon and to take down the artery. So this is the vein first. I usually use these cases when I'm really sure that I will have to take down the splenic flexure, like a very low anterior resection or an interesting anterior resection, because I believe that this approach will help you to take down the splenic flexure, which sometimes is the most difficult part of the surgery, especially in obese patients. So if I'm really planning to take down the splenic flexure, I believe in most of my cases, I do the vein first. So you see here, the Treitz ligament is right here. So I'm my third arm is pulling up the descending column, so I can have distraction and contraction with the vessel sealer and with the monopolar scissor. And once again, I'm trying to reach out for the mesocolic plane. This is a very thin patient. Sometimes thin patients sometimes it is more difficult to find this mesocolic plane, but here, because they have very, very few fat tissue. So now here you are seeing the tail of the pancreas, and I'm working in order to reach out the lesser sac, but still I haven't cut down the mesenteric vein because it helps me to get traction and contraction. At this point, you should be careful of not turning too much the vessel, because you can have some vascular injuries if you are too aggressive with the contraction. So you have to have that in mind. So now that I work as far as I can go in order to reach the lesser sac, and after I've done that, and now I will be ready to take down the vein first. So here you see I'm doing this window. This is a very smooth case, not very. I didn't have any trouble with the small bowel going into my planes. That sometimes it is what it makes difficult, the vein first approach. So now that I have it, then I will go again. I will move down to the pelvic face, to the pelvic face, and you will see here again. I will do here the same that I do when I go with the artery first approach. I will see here the promontory. I will see here the bifurcation of the aorta, and here will be my sigmoid fossa. So I'm ready to attack the artery, And at this point, again, I think this is where you should be very careful trying to find the nerves that goes down to the pelvis in order to get better functional outcomes. So here I try to dissect it. Again, I have here the ureter. I usually don't cut down the artery until I'm sure my ureter is right there, is behind it. I think it's the safest spot before cutting the artery. So here I continue working along the trajectory of the ureter, and I will be ready to take down the artery. So once again, I do it with the vessel sealer, and then I will go lower as low as I have to go if it's a sigmoid resection or a lower anterior resection. This is another example. Now you see more difficulty in trying to expose. I have more small bowel, more fatty tissue here. Once again, here I have the trace ligament. I am pushing up, and my third arm is pushing away the descending column, and with the vessel sealer and with the scissor, I'm working with the traction and contraction beneath the mesenteric vein. So I'm working here. Once again, I'm trying to find this plane of in between the urotas and the retroperitoneal fat tissue and the mesocolon. And I think that once you find this plane, the surgery goes very smoothly. You see there the urotas. I still haven't cut down the mesenteric vein. And as you see here, once again, I recommend to keep an eye on the traction that you are doing with the vein, because I insist sometimes you can have a vascular injury because you don't have a proper traction here, or you have an extra traction. So now I'm dissecting again the vessel, the inferior mesenteric vein. I really like to work with the vessel sealer. I'm ready to take down the mesenteric vein here, and I will cut it right here. My third is helping me with the traction, so I can see the vessel, and I can decide at what level I will cut down the inferior mesenteric vein. So here I'm done with the mesenteric vein, and then I will go with the artery. After I'm done, after I reach out as far as I can, as I said before, until I reach here. You will see the tail of the pancreas, and I will keep on working until I reach the lesser sac. As you see here, I'm keeping my work as high as I can. Here I will open up the lesser sac. You will see right there the spleen, and then I will do the splenic flexure takedown, as Dr. Elois just showed us. So once I'm done with this part of the surgery, when I'm doing the vein first, then I will go and find the artery. At this point, once again, my anatomic landmark will be the sigmoid fossa. And as you see here, I'm working at this point. You see here the inferior mesenteric artery. Once again, I'm trying to look out for the mesocolic plane, which is very clear and very nice here shown. So back there I have the ureter. Right here I have the aorta. So once again, the ureter, it's here. I have to work in this plane, in the mesocolic plane, and try not to get confused in between planes. So this is the artery, and this is where my plexus, my venous plexus will run. So it is important to try to find it, because if you cut here the artery, you will have problems with the function. So you have to cut the artery a little bit above the nerves, above the nerves. So at this point, I'm ready to take down the inferior mesenteric artery. Here, as you saw before, I had the venous plexus, and I just cut the artery, and I will be ready to continue my surgery, if it's a sigmoid cancer or a rectal cancer, to go down and attack the mesorectal excision. So does the approach matters? I'm not really sure. I think there's not enough evidence whether we should do the vein first or the artery first. there are no difference in oncologic outcomes nor in pathological outcomes. And some studies are trying to reach out if there are differences in functional outcomes, which I believe it depends more on which level of the artery you are cutting. Morbidity, it will be the same, but if you are not experienced with the vein approach first, I think the learning curve is a little bit higher for the vein first than the artery first, in my opinion. And there are some studies that says that conversion, it can be lower for the vein first. Anastomotic leaks, there are no difference, and it will also depend if you are going to take down the splenic mobilization or not. This will increase the difficulty of your surgery, as you know. And I really learned this approach. This was published by Armando Molani, and I really learned this approach, the vein first approach, from my friends from Barreto, from Dr. Melani, from Dr. Romagnolo, from Dr. Denadai, and Dr. Carlos Veo. I think they are one of the pioneers in propagar this kind of surgery. They have really good outcomes, and the technique is just beautiful. And what I do, I just learn from them, and I try to do as good as they do. So there are some studies. This is a randomized clinical trial that compares initial vascular versus vein, artery versus vein in the inferior mesenteric artery for laparoscopic surgery. And they are comparing conversion, surgical time, bleeding, morbidity, mortality, and pathological outcomes. And what they found out was that they have a higher conversion rate in the inferior mesenteric artery first than in the vein first. And they didn't find any other difference in outcomes, nor pathological or non-functional. This is a randomized study that it's running. I didn't find the final results, but they are trying to assess the functional outcomes in the vein first approach versus the artery first approach. I think it will be interesting to see what they find out. And well, in conclusion, I think there is no difference in outcomes. I think we should be very accurate with the knowledge of vascular anatomy. I think surgeon's experience matters. Patient selection is also very important. In some patients, it will be better to start with the artery first, and in some patients, it will be better to start with the vein first. And I think surgeon must be confident with both approaches. So, muito obrigada y muchas gracias.
Muchas gracias, Itzel. First of all, I would like to say that you look very well in the Brazilian soccer t-shirt. I'm very happy that you enjoy our gift. It's a small gesture of gratitude for your participation. And thanks for sharing the evidences we have about this issue and showing your videos of both approaches. I'm sure we have a lot of questions for you in a few minutes if you stay with us. Thank you. So, right now, acho que eu vou falar em português, né? Eu gostaria de chamar agora, então, o Dr. Luiz Gustavo Romagnolo, que é conhecido de todos nós, e aqui eu tenho que abrir um parênteses que eu sempre faço, já fiz na primeira e na segunda edição desse nosso evento. O Romagnolo é o idealizador desse simpósio, no ano de 2020, e então se a gente está fazendo esse evento e já na terceira edição, tomou corpo, agradeço a ti, meu amigo, e agradeço não só por isso, mas agradeço também por ter sido responsável pelo treinamento do nosso serviço de coloproctologia do Hospital Moinhos de Vento nos últimos anos. Tu, em companhia dos teus colegas do Hospital do Amor de Barretos, a quem eu também agradeço, então, Carlos Vel, Marcos Denadai, Maximiliano Cadamuro, que nos ajudaram muito e ainda nos ajudam muito. Vocês são nossa inspiração aí para seguir adiante na cirurgia robótica coloretal. O Romagnolo, sou obrigado a apresentar ele, né? Faz parte da formalidade, embora todos já conheçam, ele é coordenador do departamento de oncocirurgia coloretal do Hospital do Amor de Barretos e coordenador científico do IRCAD América Latina, unidade de Barretos, e é vice-presidente da Associação de Coloproctologia do Estado de São Paulo, além, obviamente, de um baita amigo nosso. Romagnolo vai falar para todos nós a respeito da abordagem medial-lateral versus a abordagem lateral-medial na colectomia esquerda robótica. Tudo contigo, meu amigo.
Bom, pessoal, primeiro, bom dia. Eu queria agradecer ao convite, né? Queria agradecer ao Thiago pela oportunidade de estar aqui conversando com vocês sobre esse assunto. E a ideia, na verdade, eu só fui que coloquei a ideia e expliquei um pouco para vocês o que era e vocês que criaram todo esse evento. Então, parabéns pelo pioneirismo, parabéns por todo o desenvolvimento do projeto aí, de como vocês estão trabalhando, e esse evento é fantástico. E em consideração a ao pessoal que está assistindo e que está apresentando, como a Itzel e o Eloy, eu vou falar inglês para ficar a apresentação, porque português não é muito fácil, às vezes, para eles entenderem, que a gente acaba falando muito rápido, não tanto quanto o Ramon, mas a gente vai acabar falando um pouco bem. Bom, so let's change. And my idea now is to talk about lateral approach and medial to lateral. This is a difficult to talk. So I don't know if can you see my screen? Can you see my slides? Okay.
Yes, we can.
Okay. So oh, just a second. I think that I changed something here. Okay. Now it's okay. Wait, I changed something. Just a second. Okay. So tá dando acho que microfonia, o Thiago. Eu não tô conseguindo. Podemos? Vocês estão me ouvindo? Tá tudo bem?
Tudo bem.
Tá tudo certo? Não sei. Tá um pouco, tá dando microfonia aqui, eu não tô conseguindo entender nada.
Romagnolo, só compartilha, por gentileza, a tela novamente. A questão da microfonia a gente vai resolver agora em seguida.
Aqui. Ok? Tá certo?
Sim.
Perfeito. So the idea about this is to talk about lateral to medial and medial to lateral. After Itsu and after Eloy explain about these ideas, it's not easy, but it's more important to discuss about the ergonomy and how to talk about this. When you use lateral to medial and when you use medial to lateral, the idea is to talk about the position. So the trocar is the same. It's the same idea, the same position to do the procedure. So I'm show some videos to explain about this. So when you talk about medial to lateral, this is the laparoscopy way to operate in surgery. So why is the problem when you use medial to lateral? It's easy for our brain that the most of the surgeons that start to do robots, they already done so many laparoscopy cases. So the idea is this is the laparoscopy way. But why it's easy for us? It's easy because our brain, it's completely agree with this idea. So the problem is this is not a robotic way. Why? But it's not possible to do this surgery so deep. Why? Because you have to keep the eyes and the instruments in the vision of the console. So when I'm discussing here for you, to showing the surgery for you, you can see my right arm here. It's good to do this kind of approach, but when you see sometimes my right arm disappear and you can fracture the vein or sometimes the artery because the arms of the robots, you cannot have sensation. It's not easy. So what we do to avoid this this problem? So first I'm doing the dissection as a laparoscopy way, doing the vein above the vein first, And you can see in this draw, you can see the pancreas, you can see the origin of the vein, and you can see the way that you do in laparoscopy. You can repeat the same. Find the lesser sac, open the lesser sac. So it's easy for understand. When you talk about training people, training surgeon, you have to understand the best way to train the people. We don't have numbers about the quality, about oh, this lateral way or medial way is the best because it's best for you, best for me. But we have to understand about training. And this way is not new. It's the laparoscopy way to do the surgery. So that's way what I'm doing. I'm doing the same when you do laparoscopy surgery. I'm taking the vein first. I'm using the clip. I don't use vessel sealer. I have a bipolar in my left hand. I have the scissor. I don't use the hook. I like to use the scissor because scissor is like a spatula. It's easy to dissect. It's the shape. So after to take the vein, we open the tissue, the fat tissue close to the pancreas. You use this way to do laparoscopy, and you use this way to do robotic. It's easy to understand, but there are some rules to find this plane. First rule, always put your two hands in front of eyes. Second rule, don't do any movement with tough, with difficult, with hard movements. Why? Because you don't have haptic feedback, so you cannot understand our power to do the dissection. So what I'm doing it's not edit video, so you can see how speed we are doing the dissection. So you have to be aware to have some bleeding, especially in the pancreas, because some kind of bleeding is not easy to stop. Sometimes you have to do some stitch. So when I am showing this video, you can understand because this is the way that we do laparoscopy. So that's why we prefer to teach in the beginning our surgeons this way. Why? Because it's more comfortable for our eyes. So this is the same way that it's a show and it's a law showed. So this is the best way. No matter if you have an obese patient or slim patient. So after to taking the vein, take the vein, you are going to artery. And one thing that we love to do is to take the artery in the region first. Why? As you can see here, I find the nerve first. I'm going to origin. As you can see, the nerve are close to the artery here, so I can dissect only the origin of the artery. I can use all the end wrist of the robot to dissect. And because I don't use vessel sealer or energy advanced device, I prefer to use clips and suturing. This is the best way to do. After you take in the artery and you take the vein, you can open in the field. And that way, it's possible to do dissection medial to lateral to avoid some problems. So you have a big window, you can see the big field, you can dissect, and you cannot have any problem with the veins or make some problems to avoid some problems. So this is the way that you do medial to lateral. It's nice. So after that, when you finish, you go lateral to medial. Okay? This is easy to understand because this is the way that you do laparoscopy. When you do think about robots, so that's why you have to change our mind. So, and let's talk about anatomy. When you talk about anatomy, Eloy show a very amazing video talk about Toad's fascia. Hey guys, when we study learn about surgery in our medical school, in our residence, we learn about lateral approach always. Why? It's much easy because our hands it's inside of the body. You can put your hand doing traction and contraction. And Toldus fascia is the correct anatomy to start, because Toldus fascia is the way that are a fusion of the planes. It is the embryologic plane. And when you talk about the robot, we talk about 3D camera. We talk about endowrist, the way that you use our eyes. When you do open, you put your hand, you do a traction with the column, and you do this dissection using your hands, the way that you do robot. So when you talk about anatomy, we have to understand that when you have to do lateral, medial to lateral, you have to find the plane. The plane doesn't exist. You have to find the plane. You have to open the window. You have to find the pneumo with the pneumoperitoneum, the dissection. This is when you do lateral to medial, the Toldus fascia exists. Just find it and start the dissection. So that's why there is a point, there is a arrow to showing for you, the same arrow sign in the CAT scan, the arrow that's okay, start here. So this is much easy. This is the robotic way to study. So, and then you talk about ergonomy, try to do lateral to medial in laparoscopy. Why you change to medial to lateral? Because it's much easier in laparoscopy, because you are straight, you are going forward in the front of your eyes, the dissection. When you do lateral to medial in laparoscopy, it's good, but it's not good enough, because you don't have in the wrist, we don't have a curved dissection. It's possible, we know that, but it's not easy. So the idea is to talk about this way. I'm showing this video for you because this is the way that the robots approach. It's like embrace the tumor. So this is the way that you have to understand the idea. No matter if you have XI or X or SI, this is the idea. Think about robots. And that's why I'm showing, this is the one video talking about lateral to medial. So the first approach is taking the artery. Start taking only the origin of the artery. Open the window, find the artery, because the artery is here. This is obese patient. So as you can see here, I'm taking the artery. Just a little bit more faster here. So, okay, done. The artery is done. So we put a gauze there. I'm showing it's finished the taking the artery, dissect a little bit to put a gauze there. So we put a gauze and we are done. So we are starting lateral to medial. It's not necessary to take the vein, because the vein is not the embryologic oncologic plane. So this way I'm starting to do lateral to medial. And that point that I'm showing now is the point that the most of the people have to be aware, because the ureter is close here. So when you have the 3D camera, you have the closer dissection, so you can see the structure. The same video that Eloy showed before. So that's why we think that lateral approach, it's much easier, but the question is, so do you think that you have to do for all case? No. First, you have to understand the idea about robots. Start doing the medial to lateral. Start doing the way that you do laparoscopy. So when you be comfortable to use this technique, you can change. You can do everything, lateral to medial, upper, superior part first. So, but we believe that this way is much easier to understand the technique. So just to show for you about the dissection is the same. The idea is the same, but you can see I'm in front of the tissue. I'm using my left hand to do as my left hand in the open surgery, doing a traction and contraction and doing the dissection. You can see the fat of colon, the fat of the retroperitoneum. You can see all the possibilities, and I'm showing this is gonadal vessels here. The ureter is closed here. and you can see all the dissection. At the end, I'm finishing the dissection. I can find all the medial approach that I did when I take in the artery, and you can see all the splenic fracture are done. And you can do a left colectomy or low anterior resection or ultra low resection. You can take the spleen dissection. That's it. So the idea is, we don't have numbers, we have experience. The idea is, try to understand the anatomy first. Try to understand the ergonomy first. Try to understand how robots work first. After that, you can understand the surgery. We're not talking about laparoscopy, we're talking robotic surgery, and you have to talk about how to think in robot way. And this is the way that you can discuss. So this is the idea. This is the way that you can do, you can give for you. There are so many options. You can choose your best option, and this is the way. So thank you so much for the opportunity to be here, and we can open for discussion if you have any doubts. Thank you.
Thank you, Luis. Thank you for your presentation. And I completely agree with you that we first need to master one approach, and then we can choose to move to the other approach. And of course, there's the way that you can do the best for you, but probably we don't have scientific evidences that one approach is superior than the other approach. Well, let's go on with our discussion. For this session, I would like to call 4 colleagues from Hospital Moinhos de Vento. Heloisa Guedes Musnich, who is our colleague from our service, Dr. Vitor Binda, Dr. Ricardo Cunha, and Dr. Rui Takashi Koshimizu, who work in our staff in Hospital Moinhos de Vento. I will start with Dr. Heloisa, please.
Hello, good morning to everyone. I'd like to thank you for this opportunity to be here discussing such good points for to learn our techniques in robotic colorectal surgery. And thank you, Thiago, for inviting me to be with all these honored colleagues with these great presentations. Well, I'd like to do 1 and 2 questions in sequence. As we know, the ligation of inferior mesenteric veins is okay for rectal tumors and sigmoid tumors, and even to distal left colon tumors. I would like to know for the panel when there are more high left colon tumors, or even in the splenic flexure, if they do the ligation of inferior mesenteric veins, or if they selectively do this. And if it is selectively, if they work with images before the surgery to understand the vascularization. As we know, the blood supply to splenic flexure is very variable. Thank you.
Take this. Professor Lai, I think you are mute.
I will start with this. Thanks for the question. I think it's very interesting. We take the inferior mesenteric vein on the inferior part of the pancreas only when we do a TME surgery in order to get more length of bowel to get to the anastomosis. If we do a left colon partial or sigmoidectomy or partial mesenteric excision, we take the vein just parallel to the level of the of the artery. We don't go up there and take it. So we normally leave the left colic vein that is draining to the inferior mesenteric vein. So the only time that we take up there, it's on the total mesenteric total mesorectal excision, and it's because of length. It's not because of oncological reason.
Yeah, I agree with Dr. Eloy. And sometimes just taking down the vein at the level of the pancreas, there are some studies that says that you can reach maybe 10 to 12 centimeters more of colon. So if I'm doing a very low anterior section or an intersphincteric resection where I do a colon anastomosis, I will take down the splenic, the vein at the splenic, at the level of the pancreas also. But for a sigmoid, I will do exactly what Dr. Lois Finn said.
And if it is in the upper left column, you do it selectively?
You mean a left colectomy, upper left colon, close to the splenic flexure? Well,
exactly.
Yes. What we do there is what the French call a high left colectomy or a partial. Yes, we take the left branch of the medial medial colic artery and vein, and we take the left colic artery, and a lot of times we take down also the inferior mesenteric vein because it's very difficult to do a really good surgery there. Then I agree that in some patients it could be a problem. I agree, but you know one thing, when the vascular surgeons go for an aorta surgery, the first thing that they do is they take down the inferior mesenteric vein. This is the first step that they do. And normally it happens nothing. Yes, so probably a lot of times we are just exaggerating the role of this vein. I agree that in those cases, a lot of times they have collateral veins. Yes, but trying to preserve the inferior mesenteric vein, it can be done, but I think for teaching purposes, it's not easy. And it's something it's related to a more expert surgeon on that. Yeah, it's not difficult, but it's not easy.
Eloisa, I think that one thing is to understand is when you talk about left tumor or left colectomy, what's the position of the lesion that you have to do a resection? So if you are talking about tumor, you have to do 10 centimeters radial, medial, lateral, upper. So to understand if you have to take the artery and the vein, because sometimes you are in the middle of this. So, and the vein is not important. Important, it's the marginal arcade. So one thing that I like to do in some cases, it's not for all cases. So before, when you have this kind of tumor, I do a CT scan with the artery phase first to understand the marginal arcade. So this is the first one, preoperative. Doing the surgery, one thing that's nice to do, it's to understand the vascularization during the surgery. So one thing that I like to do is I dissect the artery, left artery, and not taking it. I dissect the lefty branch of medial colic, and what I'm doing, I'm using some clamps, hemostatic clamps. I just put the clamps and I do ICG test. As you can see, if you have irrigation above, you can see if you have proximal irrigation, and if you are good, you can do the anastomosis. But the idea is taking the vein. You have to talking about the approach of the venous drainage. So this is why. So the most of the people, it's a tactical approach. Take the vein to do the very nice anastomosis. This is the way. So you have an upper tumor, you have to take the vein. It's not important. So this is it's difficult case, but so you can take the vein.
Thank you very much.
Dr. Victor Binda, my colleague of team, would you like to address a question for our guests?
Yeah, Chuck, first of all, I have to say I'm very happy to be here because I'm a beginner in robotic surgery and I have a lot of doubts to talk with you. And we had a great presentations. And I would like to ask you, Dr. Itzel, about the position of the trochlears. And sometimes you may be faced with the necessity of taking the right column to do an extended right colectomy to take a tumor of the left column. To this diagonal position of the trochlears put some kind of difficulty in our surgery? Professor Aloy, I'm not seeing Dr. Itzel in the screen now.
I think we lost her.
Yeah, you were asking about the position of the trochlears, yes?
In the case you have the necessity of taking all the right column with the left column for any reason.
Then, if I know this from the start, what I do is a suprapubic approach, because it allows me to do a right and left column. Yes, if for any reason I'm already positioned with those trochlears, as I said, then what I have done is to do the left column and then to a boom put the boom on the reverse and then go from there to the right. Sometimes it's not easy, and sometimes you have to put one or two trochlears more to the median laparotomy line to allow to complete that. But if I know from the beginning, before starting, I do a suprapubic approach.
Sometimes we have operated on patients with a malignant polyp that has already been taken. And we have the area with a tattoo, but we are not very sure about if it is the middle of the transverse column, the left column, and the right column. Do you ask for some kind of marking before the surgery? How do you put your first trochlear to put your line more to the left of the patient or to the right of the patient?
Sometimes what I do is a small supra-umbilical trochlear where I put the camera and then 5 millimeters on the fan steel incision that I'm going to do on the suprapubic, and from there I look at the tattoo lesion. Yes, normally we don't do other marks with clips or whatever. We use the tattoo, and normally with this we have enough. I don't know if it's the same that happens to you. I think.
Sometimes, if I have any doubt, well, in most of my cases, I just switch and I start with the suprapubic incision, because anyway I will take down the specimen through the suprapubic incision. So I use my retractor there. I put the Alexis cup there, and my first trocar will be at the Alexis port in the retractor, in the suprapubic incision, and the pneumoperitoneal I will do it through the suprapubic incision. So at this point, I have the option to look all over the cavity, and I can decide better where I put my trocars. So I've been switching to this, and right now this is my first step of the surgery, doing the suprapubic incision and putting the Alexis cap and start the surgery. And from that point, I will decide where I will put the rest of the trocars.
Dr. Raniola, I have
Dr. Ricardo Coelho. Sorry, Victor, sorry. No, go on.
Okay. I will return
we still have a few minutes in this session. I would like to give the opportunity for our colleagues to do questions for our guests. So Ricardo Cunha, would you like to do your question?
Okay, good morning. I would like to congratulate the organizing committee for the brilliant event. It's so easy watching the classes. It's lovely. This is a challenge need to ask for in the final. But generally, most of us are in the learning curve technically, and how to explain the patients the difference, the techniques, robotic and video laparoscopy. So the question for the three guests is how to fix the technique in the learning curve in the face of video laparoscopy, so established in our environment.
Okay, can I? Okay. So I think that the best way that we do, Ricardo, it's a great question. In the beginning, we have to understand the environment of the surgeon. The most of the surgeon that we need to learn, they start into training. The most of them, they are very experienced with laparoscopy. So, and the most of the surgeons in Latin America and Brazil, mainly, learn about medial to lateral way. So that's way we prefer to teach medial to lateral. And after some case, we can give some opportunity to, okay, let's show for you the lateral to medial. Why? Because if you start for this kind of surgeon, lateral to medial directly, it will be a confusing their minds, and they can avoid the robotic way. Oh, it's so difficult, I cannot understand. So instead of this, I have some case with some surgeons completely naive in laparoscopy, and they start to do robots. And this kind of surgeon, it's much easy to teach lateral to medial approach, because in that mind, it's much easy to understand lateral approach. So that's why we prefer to start medial to lateral, and after that, change lateral to medial. That's the best way that we believe that could be the way to teach in the beginning.
What our Spanish guests think about that?
I think it's a difficult, it's not easy question. I think for a start, I think that you can start both. I think for starters, it's more easy to do the first part of the lateral to medial because they are more used to this in open approach. I think it's when you go from medial to lateral, I think it's more easy to start with the vein than with the artery. So I would start first lateral to medial, then medial to lateral starting with the vein, and the last part I would teach is the artery. But it's not so difficult neither. But always you have to go and see. Then you have the ideal is to have mentors that teach you to there. But I would do that progression probably. I don't know what Itzel thinks.
For me, I just learned it from medial to lateral, and I learned it going first with the artery. And as you said, it's not that difficult. You just have to learn to see where are your landmarks. And in each approach, you have a specific anatomical landmarks that you have to learn to identify. If you are able to identify these landmarks, for example, for the arterial first approach and medial to lateral, you have to find the promontory, you will have to find the aortic bifurcation, and you will have to find the sigmoid fossa. So if you are finding these landmarks, you are ready to go. And with proper traction and contratraction and techniques of advanced minimal advanced surgery, you will be able to standardize your technique. But for me, it's because I learned it that way. I started from medial to lateral. I think it's for me, it's easier to start with the artery, and that's what I teach my residents. And I've never done the lateral to medial approach. Only if I have to do it, I do it. But it's not an approach that I use, because most of our patients are for rectal and colon cancer, and we also always do the medial to lateral approach. But I think the thing is to standardize the technique and find your anatomical landmarks.
Thank you.
We still have time for 2 more questions, and before we move to the last session, one from Professor Rui Takashi Koshimizu, and just after that, from Professor Paula Martini. Sorry, Paula, I forgot to introduce you in the beginning. Paula is also a colorectal surgeon, member of our hospital, but she works in Santa Maria. So please, Rui.
Okay. Good morning. Thanks and congratulations for the presentations. My asking is for all the presenters. Like in previous session, how is your thinking about the lymphadenectomy, the D3 lymphadenectomy in left colon, mainly in descending or in splenic flexure tumor?
I think, if you want, I think it's the D3 on left colon. I think it's much more easy than in right colon, because the anatomy is much more stable than in the right colon, and we have not so many structures that we can damage. Yes, obviously it's the ureter, obviously it's the pancreas, the splenic vein. But I think it's not really difficult. There are a lot of, as Itzel said, there are a lot of landmarks. You have to go to the root of the artery, to the root of the vein, and then it's not such a big deal as in the right colon, that you have head of pancreas, you have the duodenum, you have the renal trunk, etc., etc. So and the anatomy is much more has a lot of alterations. So I think it's much more commonly done a good D3 in left than in right colon.
I think here the clue is to do a proper vascular ligation. Maybe you can have 1 centimeter from the inferior mesenteric artery, because we have had cases that they recur, they start to increase the ACE, and then you do a CT scan or a PET-CT, and the radiologist will report you an implant or a retroperitoneal tumor, and it's unique. So you go after that, and when you go to the surgery, it turns out that it's the nodule that was just in the root of the inferior mesenteric artery. So we have not so few cases in this scenario, and if you do a retrospective analysis, you find out that the surgeon did a good high ligation of the artery, and then you have the recurrence at the level of those lymph nodes, and it's still a local recurrence, and still a local disease.
Paula, do you have a question for our guests?
Hello. I want to thank the kind invitation and congrats to the presenters for the excellent classes. And I have to ask the question that no one wants, but I want to know if you had a spleen injury in this dissection, and if you had, how do you manage this?
Yes. Sometimes we have had. It's not very common at all. Most of them are small tears on the capsule due to the traction, And normally, the first step is put a swab, a gauze, hold it there. Normally, you can even use the energy there. If it goes on and on, you can put other products like Touch-A-Seal or whatever, and you can do even Flow Seal, etc. And it's very, very seldom that you have to take out make an splenectomy. If you have to do an splenectomy, what it's advised is to try to get some part of the spleen and put it and wrap it with the omentum in order to try to have less problems in the long term. But normally it's a tear, and with the swab, patients, some energy and protection, it's enough, normally.
So I just had a case.
Is that the situation?
So this was a male, and he had this chronic renal failure, and I don't know if that was associated to easy bleeding, because since we started the surgery, we had bleeding everywhere, and when taking the splenic flexure, we had this tear in the capsule of the spleen. So we started all the steps that Dr. Lloyd just told you, the gauze, and then I put the gauze there and I continue working. I continue doing the total mesorectal excision, then I returned and it was still bleeding. So I put another gauze. It was still bleeding. Then I put the hemostatic products that we had, and he still was bleeding. So in these steps of waiting and see, we had lost around maybe 800 cc's of bleeding. So at some point it was very difficult. Like I have now I have 800 cc, and it was very difficult to put the ports in order to and I had the X, not the XI. So it was very difficult to approach the spleen, and I end up doing an splenectomy. I assist the surgery with a left infracostal incision. It wasn't very big incision, but I have to assist the surgery in order to do the splenectomy. So this is my one case, and I just had it like maybe 2 months ago. So sometimes you will end up doing an splenectomy.
Okay. Unfortunately, we have to go on in our scientific program. I would like to thank all of you for sharing your experience. I'm sure that we all learn a lot in this session. Thank you very much. And
thanks a lot.
Gracias.
Gracias.
Thank you.
Gracias. Bye-bye.
Obrigada.
Bye. Okay, so let's go to our last session that will be dedicated for rectal cancer. In this session, we will start with a presentation of our friend from Minas Gerais, Professor Rodrigo Gomes da Silva. He's associate professor of the Department of Surgery at the Medical School of the Federal University of Minas Gerais, and he's also a preceptor of the residence at the clinical hospital of that university. Rodrigo will talk about urgent conversion in robotic surgery, a difficult issue, but I'm sure he will answer many doubts that you have in this situation that we have a lot of fear of this, but he will solve all these problems for us. Rodrigo, feel free if you want to talk in English or if you want to talk in Portuguese, you decide, okay? Thank you very much.
Thank you, Thiago. Vou apresentar em português mesmo. Deixa eu tentar aqui compartilhar minha tela. Compartilhar, ok. Deseja gravar? Ajustes? Ou negarem? Deixa eu ver. Espera aí. Estou tentando compartilhar a tela aqui.
Estou conversando aqui com o Diego da nossa parte de TI. Ele está propondo a gente.
Janela
Tu consegue
tela
compartilhar?
cheia.
Senão a gente.
Não, acho que eu consigo. Tá compartilhando com vocês? Não.
Não.
Agora?
Uma proposta que eu ia te fazer é te passar para a segunda apresentação, ou eventualmente terceira, aí tu conversa com o Diego ali e a gente retoma em seguida. Eu vou adiante com o professor Hans e com o Nuno, eventualmente, tu volta. O Diego te atende ali no chat, pode ser?
Tá bom, pode ser. Beleza.
Então tá, obrigado. Okay, so let's change the sequence. So we'll call Professor Handenwild. Good morning, Professor.
Well, good afternoon here, but good morning for you all.
Yes, you are 5 hours, ahead of us
Yeah.
in Netherlands, yeah? So right now it's almost 4:30, yes,
It is.
Your Professor Handenwild is Professor of Surgical Oncology at the Medical School of difficult to pronounce. Please help me. Hamdenbunk, Netherlands. Is that correct? Yeah?
Good enough. Radboud.
Good enough. And he will talk about the step-by-step in total mesorectal excision with robotic assistance, of course. Professor Handenwild, thank you very much. The floor is yours.
Can you see my slides?
Not yet.
Okay, then I have to change something. Wait a sec.
Okay, but
because we tried it already.
it was good. It was good before. It was good before. It was perfect.
Yeah. So
now we can see. If you want to try again.
So I go to present.
And only open in the presentation mode. Full screen.
Is this better?
Let me see. Oh, okay, perfect. Right now it's perfect.
No? You got it?
Yeah. Great.
Okay.
Yes,
well, first of all, yeah. Okay. First of all, thank you very much for the invitation, and for me, it's a great pleasure to present in this conference because I saw already some very excellent videos and some very good presentations. So I feel very honored to be in this Brazilian conference. These are my disclosures, not very special. And my presentation, I will first give a brief introduction about rectal cancer surgery and robotic surgery versus the other techniques and the research that is done. Then I have a video with a step-by-step case of a partial mesorectal excision, and I would like to end with some conclusions. Now we have to face that we are currently in an era where rectal cancer treatment is completely different than, for instance, like a decade ago. It's all about multidisciplinary team decisions. We have excellent MRI staging. We give quite a lot of patients neoadjuvant treatment, local excision or beyond TME when necessary, or organ preservation when possible, and everything with standard pathology. So I think it changed extremely in the last 1 or 2 decades in very different techniques and very different options for each patient. Now, as surgeons, we also have various options, obviously. This traditional laparotomy, then most of the people, I think, especially in my country, will perform colorectal surgery laparoscopically. There was a tendency to start with TATME in several hospitals, but in our country, a lot of hospitals, and I think this is almost a quarter of the hospitals, are now performing rectal surgery via the robot. Obviously, for rectal cancer surgery, there are some pros to perform robot surgery. You have the perfect 3D and very close vision compared even to laparoscopy. The advantage of the articulating instruments is obviously, but also the ergonomics of the surgeon. And this is different from, for instance, left or right hemicolectomy, where the surgeon can stand relaxed in a laparoscopic procedure. But for every rectal cancer surgery, I think it's always a fight between you and the assistant. You're always a little bit in a non-really relaxed situation, I think, if you do the surgery laparoscopically or open. And obviously, after if you sit behind the console, it's very economically for a surgeon. Another big advantage is the stable camera. You perform the camera yourself. You can never complain at your assistant about camera work. And I think it's a very good teaching instrument, because you can sit next to your fellow or next to your resident. You can point out on the screen, and it is very nice to do that. And obviously, if you use ICG Green, you have the Firefly mode easily on the robot. Obviously, there's some cons as well. And no sense of touch. You'll miss the tactile information. You have the docking time, and especially in emergency conversions, it is quite a problem that you might lose time. Although I have to say that an emergency conversion, and I have to say, not yet has this been happened to me, but it can happen, and then it will definitely take time. But the most disadvantage is obviously the cost and the ecological footprint of this whole procedure. Now, there is a lot of randomized trials that have been done comparing open to laparoscopic surgery without any oncological differences. Everybody knows the a la carte trial and the color trial, but also the roller trial, obviously, that compared robotic surgery compared to laparoscopic surgery. And there were no oncological differences. We did quite a lot of studies in the Netherlands comparing high volume hospitals, laparoscopic surgery versus robotic surgery. And also, again, no difference if you look at retrospective data between the two techniques, although both in TATME and robotic surgery, we tend to do more low anastomosis. So in a laparoscopic patients, it was more often performed that colostomy was done and a APE was performed in patients, where with robot or TATME, you can perform much lower anastomosis. But this is all retrospective data. However, there's a quite recent study in the British Journal of Surgery, and this is from, again, high volume, very well-known surgeons, Jim Kahn, Quentin Denos from France, Philippe Rouenet, also from France, from Montpellier, and a few very big centers in the Netherlands. And they only looked at their overweight and obese patients. And again, robotic TME compared to laparoscopic TME, lower conversions to open surgery, and again, less often a stoma, so more very low anterior resections, especially in the obese patients. But the interesting thing about this paper, and this is a very interesting paper to look at, is that if you look at the operating time, and these are the best of the best surgeons, at least 3.5 hours for a robotic TME surgery, but also a length of stay 6 days. Everybody is presenting data of 3 days. No. This is expert centers, 6 days. Expert centers, mortality obviously 0%, but the 30-day complication rate 40%. So this is how it works if you present honest data, and this is all current patients, and this is done in a propensity scored matched analysis. Yes, those were patients who were overweight and obese, but this is how it probably works in my and in your institution. And we don't have to be ashamed for results like this. But importantly, with robots, robot operations, less stoma and less conversions. Now, no difference in the ROLA trial in any functional outcome. If you look at sexual function in both men and women, no differences between laparoscopy and between robot surgery. What about learning curve? We did a study in the Netherlands about the learning curve, and you can see the figure on the right side where you see all the intraoperative complications between 7 surgeons, and you see that there is differences between the surgeons, but it is very uncommon to see it, and it changes throughout the learning curve. Some surgeons have no intraoperative complications, and some have them at the beginning or even while they are still operating. But interestingly enough, if you pass this learning curve, then operating time will go slightly down, but still complications are there even during the learning curve or after the learning curve. But the conclusion of this paper is that training in robotic surgery is safe, and it is in between 12 and 35 procedures that you pass your learning curve. So this is an important message. It is rather easy if you're an experienced laparoscopic surgeon or if you're an experienced open surgeon to get trained in this technique. So I think that nowadays in open surgery is only for the hostile abdomen, or for locally advanced or recurrent disease. And you can use all the different techniques, but I think that with TA-TME and with robot, you have definitely less stomas if you look at all the data presented nowadays. But the oncological data are more or less the same. So how does it work in our center? And it has been presented previously also, that if you have to do a low anterior resection with mobilization of the flexure, and we don't do it standardly in every patient, then you have to place your trocars a little bit more, let's say, vertical, and you can place them more horizontal if you do not perform a flexure mobilization, or in those patients where you perform a perineal excision. The order of the robot position is similar as we have seen now in the previous videos with the tip-up. I always use the tip-up and the bipolar, the camera on 2 and the scissors, or when you needed the needle driver, and sometimes the stapler in your right hand. So I would like to present now the case we did 2 weeks ago, and I will just walk you through. And as you can see, you can have very close vision of your operation, and you can do everything very nicely. I did this operation, by the way, with a resident. So some parts are done by the resident and some parts are done by myself. And here you can see where we do the adhesiolysis, and then we have the whole setup for basically starting the low anterior procedure. And so first we release all the adhesions, and then we start with medial to lateral. But I think one of the advantages is that you can, especially in robots, you can easily flip over and go from medial to lateral as well. Also, look at the very, very close vision. And this was the assistant going there. And then you can easily say, okay, now go to the other side and open it from lateral to medial. And obviously the ureter will be exposed here. And I think one of the advantages of the robot is that you can, and this is, by the way, twice as fast as in the normal situation. So here the ureter is exposed, and if you see the continuation, then we have the approach to the medial side that was already exposed, and all the nerves will be on the lateral side of this operation. So then I usually continue here and go more downwards. I can point it here. Here you can see the hypogastric nerve that is nicely exposed. And here in this male patient, it was very obvious the hypogastric nerve And again, here we continued a little bit more to the vessels to open it up, to get a little bit more space and to get your specimen more upwards. And again, one of the advantages that you can have this very close vision of robotic surgery. You can really do very nice and gentle movements and expose all the vessels you want. Here we continue from the dorsal side, and again, it is twice as fast as in the original operation. But I really like the advantage of the scissors, so you can basically use it as the diathermy in an open procedure. And of course, you can do this also laparoscopically, but I see often laparoscopic movies with all these instruments where you do not see the anatomy as nicely as you can see it in these robotic cases. So here I pointed out the vessel. We will go through that vessel in a later stage. You will see it, I think, in a couple of minutes, where we took that vessel and it starts bleeding a little bit. But I was sitting here pointing at for my assistant where she had to go. So this is what I mean. You see the lines you can see on the screen, and the nerves will be nicely lateral, and you can just follow the whole. And again, I can point it out here, that green line, so she can just follow this line and do the proper TME surgical procedure. So it's a very nice training instrument. And again, from dorsal, you can go very, very deeply into the pelvis. And here you can see how we enter it with the camera. And again, follow the lines. Your assistant is very helpful with suction, but also for smoke and some tiny bleedings. And you can just easily go down and go as far as you want. And so here we further approach downwards, and then again on the frontal side you can see nicely the non-VAS fascia. You can push it away, give some traction, and then I will probably show you later on. Obviously you can see here the seminal vesicles. Here is the vessel that I pointed out previously, and then it started to bleed here. So then you can use your bipolar very easily, and then just continue. Now this part is where we did a partial mesorectal excision. It was a very high rectal cancer patient. So then I used the scissor technique. So then we go just through the mesorectal fascia and through the mesorectal fat, and you can see nicely all the vessels. Now, one of the advantages is the flip over of the camera. So here I want to look behind the rectum, and then you can flip over the camera, and you can have this very clear view of this distal part of the mesorectum, and you can see the levator muscle, and I free here the fat for the partial mesorectal excision. Then we, I also like to clip, and I use the assistant just to clip the vessels. I don't like sealing devices. I like to separate it, to do the artery first and then the vein, and do it nicely anatomically, and do all the dissections. And I think with a robot, it is very safe. One of the other advantages of the robot is that the stapling device can go very deeply into the pelvis. You can nicely perform it. It articulates nicely. And yes, same as in laparoscopy, you sometimes have to use two devices, but this is just a very common, I think, in laparoscopic surgery, especially with the rectum, because it is very broad in this part of the abdomen, of the pelvis. So all the rest is just standard. So I just quit this video at this stage. I think it demonstrated that you can do very nicely and an anatomical procedure via the robot. and this was even with in a training situation. Now, we have to bear in mind that robotic rectal surgery was still in an early phase of development, an early stage of research and expertise. This is what I just looked up in PubMed, laparoscopic colorectal surgery, 11,000 papers in the last 2 decades. But if you look at robotic colorectal surgery, it's only 2,500 papers. So it is a huge difference of research, a huge difference of experience, and even then quality is as good as in laparoscopy. So I think robotic, especially robotic rectal surgery, is definitely the future. It is very comfortable as a surgeon. You have excellent view, and everybody who will come to your unit and watch you performing surgery on a robot in a rectal surgery case, everybody will be enthusiastic. And that is something that is, to my opinion, really important, because it definitely shows that this is the way to go. And I think the future is robotic rectal cancer surgery. So I thank you for your attention. And Tiago, I thank you for your nice shirt. And as you can see, I used it already for soccer. And I will be happy to answer any questions.
Thank you, Professor Hans. And our soccer shirt also looks fantastic with you. And thanks for your presentation. The video was really great. So we will move back, and I will introduce again Rodrigo Gomes da Silva. We will talk about urgent conversion in robotic surgery. How we should do to deal with this situation, how we will manage this situation. Rodrigo, thank you very much, and if you want, you can start your presentation. Thank you.
Obrigado, Thiago, por estar aqui nesse simpósio excepcional, com vários colegas aí internacionais e nacionais. Nós vamos falar sobre o undocking de emergência, que é a conversão de emergência de uma cirurgia robótica para uma cirurgia ou laparoscópica, ou, na maioria das vezes, se for uma de emergência mesmo, vai ser para cirurgia aberta, né? A primeira coisa que nós temos aqui na cirurgia robótica em relação à cirurgia laparoscópica é que na robótica o cirurgião principal ele está longe do paciente. Então, assim, uma peça super importante, obviamente, do procedimento cirúrgico, eles não está localizado junto com o paciente, né? Óbvio que tem um cirurgião do lado, mas a gente tem também um outro grande problema, que é o tamanho dos braços robóticos em cima do paciente, em cima do abdômen, e muitas vezes em cima do tórax, e atrapalhando também a via aérea do anestesiologista, né? Eu não consegui achar um artigo com uma, como se diz, com um título tão assim, catástrofe intraoperatória durante a cirurgia robótica em cirurgias abdominais, mas provavelmente deve ser menor do que 1%, obviamente. Aqui foi 1,4%, 7 em 486 cirurgias. Mas na cirurgia abdominal provavelmente é menos do que 1%, com certeza. O que poderia fazer a gente ter que retirar o robô, né, que essa que é a definição de deslocar o robô, tirar o robô de cima do paciente, para que a gente tenha acesso ao abdômen ou acesso à via aérea. Então, a via aérea comprometida, uma parada cardíaca, isso o anestesiologista vai ser o primeiro a perceber, obviamente, enquanto que a hemorragia incontrolável vai ser o cirurgião que vai perceber, ou a equipe cirúrgica vai perceber, ou o cirurgião, o mau funcionamento do robô, né? Então, o cirurgião e o anestesiologista têm as prerrogativas ali de reconhecer o momento que nós temos que retirar o robô de cima do paciente, a fim que a gente possa ter acesso a uma laparotomia ou acesso à via aérea. O comprometimento de via aérea é mais comum em cirurgias robóticas da cabeça e pescoço, mas também pode acontecer, obviamente, né, um acidente em cirurgias abdominais. Esse undocking de emergência, apesar de, né, a gente, né, ser tema dessa aula, e é uma situação raríssima, né? Vai acontecer uma vez na vida ou nem vai acontecer, né, se nós dermos sorte. Então, mas a gente acaba que tem que treinar para que, quando esse momento ocorrer, a gente possa fazer o undocking, em vez de ser 3, 4 minutos, baixá-lo para menos de 1 minuto, né, que seria o undocking de emergência. Então, por isso que a importância do treinamento. A cirurgia robótica tem algumas situações, como nós já falamos, o cirurgião está afastado do paciente, o cirurgião principal, pelo menos, mas existe também uma questão do braço cirúrgico está em cima do paciente, há uma piora da comunicação, eventualmente, pelo menos do anestesiologista com a equipe cirúrgica ou com o cirurgião principal, que não está ligado com o anestesiologista com um sistema de som, né, como a gente está com o bedside. Então, isso pode ocorrer também. Em geral, o paciente está completamente imóvel numa mesa que geralmente é fixa, que não se movimenta com os movimentos do robô, ou a gente não pode movimentar a mesa, e o robô está completamente fixo nessa mesa fixa. Para piorar a situação, muitas vezes na cirurgia robótica pélvica, a gente tem um Trendelenburg acentuado. Não é muito o caso das cirurgias, da cirurgia colorretal, mas muitas vezes na cirurgia robótica da pelve pelos urologistas, eles colocam os pacientes com um Trendelenburg bastante acentuado. E como eu falei, o treinamento ele vai colocar uma situação de estresse simulada em um ambiente de baixo estresse para poder melhorar a interação da equipe e das competências de cada membro daquela equipe que está dentro da sala de cirurgia. A simulação, ela obviamente, ela é feita para situações que vão se repetir, no caso aqui da Fórmula 1, a todo domingo, um pit stop de uma equipe, né, fazendo eles melhorarem o tempo, não só pela tecnologia que vai evoluindo ali na Fórmula 1, mas também pela rapidez e pelo trabalho em equipe ser completamente realizado, né? Tem mais de quase 20 pessoas para fazer a troca dos pneus, por exemplo. E na aviação também nós temos a simulação como um fator de simular, né, a simulação para que a gente possa prever um acidente ou como se comportar no acidente. E assim como na medicina, muitas vezes essa situação na aviação vai ser uma vez na vida, né, ou nunca vai ocorrer. E na medicina nós também temos experiência com simulação, por exemplo, o ATLS, né, o suporte avançado de vida cardiovascular, são situações de estresse que são treinadas para que os médicos e toda a equipe ao redor dos médicos tenham a sua competência e a sua eficácia maior. Existem vários protocolos, geralmente os hospitais fazem esses protocolos, ou alguns nem fazem, né? Mas a gente acha que é importante fazer. Essa aqui é só um exemplo de como esse hospital inglês faz esse undocking de emergência, né? Qual que é as palavras que são gatilhos para que seja iniciado o processo. Aqui, se a gente fosse ler tudo, a gente ia ver que tem algumas situações que são diferentes do que a gente utiliza na nossa prática, ou pelo menos no nosso treinamento, né? Mas então eu vou mostrar alguns estudos sobre o undocking de emergência e o papel dele. Esse é um estudo aqui de Belo Horizonte, ele foi organizado pelo Fernando Augusto Vasconcelos, que é um colega nosso cirurgião do aparelho digestivo alto. Eles fizeram, então, uma avaliação do treinamento de unlocking de emergência, fizeram um grupo controle, em que eles mediram o tempo do unlocking, e depois eles refizeram o unlocking para ver se essa equipe faria um pouco mais rápido. E no grupo de intervenção, eles treinaram as pessoas, né, desse primeiro unlocking, e depois refizeram o unlocking com o objetivo de observar o ganho de tempo, né? O segundo unlocking foi no mesmo tempo do que nos dois grupos, né? Então, no grupo controle, houve uma redução de tempo em 20%, mas se você treinasse cada membro da equipe, essa redução caiu para 66%, ou seja, esse estudo mostra que é possível você treinar e é possível você melhorar a competência de cada um dos componentes da equipe. Esse aqui é um estudo italiano. Vejam que eles fizeram várias simulações em 8 meses, e do que a gente espera, que a redução do tempo de unlocking, ela foi observada, o último ponto aqui, de 55% na redução do tempo. Mas se a gente olhar o que aconteceu nesses treinamentos, houve queda acidental do material cirúrgico, poderia ser um bisturi para fazer uma laparotomia, ou uma falta de liderança em 1/4 dos estudos, né, das simulações, erro de comunicação, conflito espacial entre um membro da equipe atrapalhando o outro eventualmente, contaminação de material em 50%, e falta de sequência observada em 70%. Ou seja, a gente vê que a simulação diminui o tempo, mas ainda assim é observado erros. E se você não treinar, provavelmente isso vai ser maior. Esse é um outro estudo. Esse autor tem, para quem quiser, esse estudo, um videozinho no YouTube. É interessante esse artigo. Eles fizeram um modelo no qual o cirurgião estaria ali operando e aquele campo cirúrgico enchia de sangue, como a gente pode ver ali na foto da esquerda aqui, e aí tem um gatilho, então, para o unlocking de emergência. Aí a equipe tem que funcionar e tem que estar treinada para funcionar. O que eles perceberam com esse estudo? Que quando você faz o treinamento, você aumenta o conhecimento da equipe de todos os passos, de cada papel de cada um na equipe, naquele unlocking de urgência, de emergência, aumenta a confiança que a equipe, né, estará, caso ocorra uma situação de emergência, e também a redução do tempo, como a gente pode ver. E os passos críticos, né, eles foram mais organizados em relação ao antes de treinamento. Então, eles mostram que há uma redução de tempo, um aumento da confiança, um aumento do conhecimento, e os passos críticos são mais bem feitos. Essa aula aqui, eu sei que o Thiago me convidou, porque ele viu que nosso hospital, o Mater Dei, fez um curso sobre o unlocking de emergência, e a gente definiu que o comando seria unlocking de emergência, e que ele seria feito pelo cirurgião. Há de se ter uma comunicação clara entre os membros da equipe, para cada um entender o seu papel, e quando se deflagra o unlocking de emergência, a gente geralmente vai colocar qual que é a situação, para que todos os componentes entendam o que está ocorrendo. E, obviamente, que vai conferir se tem material de cirurgia aberta, carrinho de parada, sangue disponível. Tudo isso vai sendo deflagrado ao longo do unlocking de emergência. Então, a equipe robótica geralmente é um cirurgião no console, um cirurgião auxiliar no bedside, o anestesista, o enfermeiro, o circulante e o instrumentador. Em geral, cada um deles tem um papel. O que foi definido no nosso treinamento do Mater Dei, que o momento, o cirurgião do console é que vai definir o momento do undocking, tanto do sangramento quanto do mau funcionamento, ou ele vai receber a informação do anestesista que a equipe precisa fazer o undocking. E ele vai colocar, então tá bom, nós vamos fazer o undocking. Ele vai colocar os instrumentos abertos, né, as pinças abertas e no centro de visão para que o bedside, o cirurgião bedside, retire esses instrumentos sem que eles estejam com apreensão de uma estrutura, e assim que ele colocar ali aberto para que o bedside retire, ele já vai escovar e paramentar para que faça uma laparotomia. Enquanto que o cirurgião auxiliar, que é o bedside, ele vai remover os instrumentos e as óticas, né, e a ótica dos trocartes, ele vai remover as cânulas ainda conectadas aos braços do robô, depois ele vai recolher os braços do robô e só vai comunicar que está afastado quando desconectar a cânula, porque o robô não se movimenta com as cânulas. Então, há uma diferença do nosso docking inicial, porque a gente retira o braço, deixa os 4 trocartes no paciente, depois a gente tira as cânulas, enfim. E nesse aqui a gente retira tudo junto, como a gente vai ver no vídeo a seguir. Então, ele pode iniciar a laparotomia e nisso o cirurgião principal já está chegando ao campo cirúrgico. Já o anestesista, ele vai definir o undocking no caso de parada, aquela questão de extubação, e vai deflagrar o processo comunicando ao cirurgião para que isso seja feito. E na hora que o robô estiver liberado fora do paciente, ele vai, né, ser a pessoa que vai colocar o paciente, de tirar do Trendelenburg, que geralmente ele vai estar, para que as manobras de ressuscitação sejam feitas ou a laparotomia também seja feita, né? Então, esse é o papel do anestesista. Aqui, então, eu vou mostrar um vídeo, que foi o vídeo do treinamento, e esse vídeo tinha 25 minutos, e agora ele vai ser colocado em 2 minutos, então eu vou cortar algumas frases, obviamente, e inicialmente ele tinha 3 treinamentos, que seria o treinamento para sangramento, um treinamento para via aérea, e um treinamento para uma emergência em cirurgia torácica, que é um pouco diferente da cirurgia abdominal. Então, eu acho que vai dar para a gente entender. Eu vou deixar com o som
Rodrigo, a gente está assistindo o vídeo, mas está sem áudio. Não sei se tu queres comentar em cima do vídeo.
Desculpa, eu tô achando que está com áudio aí. Então,
Pode falar em cima do vídeo e a gente vai assistindo o vídeo.
tá bom. Então aqui nós estamos com uma parada cardíaca, o cirurgião está operando, ele vai parar e vai fazer o undock de emergência. Vejam que ele vai retirar todas as pinças e depois vai retirar todo o... Aí, tirou a ótica e vai tirar o braço junto com o trocarte. Então ele tirou, depois ele vai tirar os trocartes. Aqui ele até que tirou... Isso, aí retirou o carrinho. Aqui é uma parada cardíaca, na verdade, por isso que ele tirou desse diferente. Então, aí o anestesista vai ter acesso. Então eu vou fazer rapidinho, só porque eu achei que vocês estavam com som. Aqui, ó, houve o sangramento, ele colocou a pinça aberta e saiu para fazer para paramentar. Depois, o colega que está no bedside vai retirar as pinças, a ótica, vai elevar junto com os braços robóticos. Ó, vejam que ele vai retirar tudo junto, ó, porque ele vai fazer a laparotomia, então ele vai tirar tudo junto. Mas ele vai ter que tirar a cânula, porque senão o robô não vai movimentar, né? Então, depois que ele tirou tudo, ele vai falar o terceiro passo, tudo está, né, limpo, pode tirar o robô, e aí ele pode começar a laparotomia. Então, concluindo aqui, a necessidade do undock de emergência ela é rara, felizmente, mas o treinamento ele deve ser oferecido, porque a gente sabe que isso vai diminuir o tempo do undock, vai melhorar a comunicação da equipe, a confiança da equipe, para que no momento de estresse, de sangramento, isso possa acontecer de uma maneira mais, como se diz, até profissional e sem estresse, né? Ou com menor estresse. Só queria agradecer aos colegas que me ajudaram aqui com a aula e com, né, cederam os vídeos, e ao Hospital Mater Dei. E obrigado, Tiago, novamente.
Thank you, Rodrigo. You demonstrated that the training is essential to decrease the time for the conversion, and you presented the step-by-step procedure for the conversion, and this video was the cherry of the cake for us to learn how to deal with this situation. Okay, thank you very much. Let's go to our last presentation. I would like to call Professor Nuno Figueiredo from Portugal. Professor Nuno Figueiredo is a colorectal surgeon and also the coordinator of the general surgery service at Hospital Lusíadas in Lisbon, Portugal. Also, he's fellow of the Royal College of Surgeons. And of course, a dear friend of all of us colorectal surgeons from Brazil. Thank you, Nuno. Please, if you want to take the word and begin your presentation, it will be a pleasure.
Thank you, Tiago. I have all my slides in English, so I'll turn to Portuguese. I'll try to speak slowly. Antes de mais, muito obrigado pelo amável convite. Tiago, é um prazer estar convosco novamente. Não sei se estão a ouvir e a ver a imagem bem, mas vou haver alguma alteração. Muito bem, então vou tentar nos próximos 15 minutos responder um bocadinho ao desafio que me foi aqui apresentado pelo Tiago, que é falar um pouco sobre como fazer a cirurgia robótica em recrescimento tumoral. Hoje em dia o Watch and Wait já não é propriamente um tema muito controverso, porque mesmo em guidelines muito conservadoras, como é o caso do NCCE dos Estados Unidos, já existe perfeitamente estabelecido que é uma das opções terapêuticas e em caso de resposta completa nós podemos seguir estes doentes dentro do protocolo e da guideline. Ora, isto é algo de novo, algo que, enfim, todos nós estávamos habituados a ouvir só em áreas mais experimentais e mais de investigação, E obviamente todos nós queremos que os nossos doentes, depois de terapêutica totalmente neoadjuvante ou quimiorradioterapia ou radioterapia, venham a obter aquilo que se chama a resposta clínica completa, ou seja, o desaparecimento da lesão no toque retal, na endoscopia e também na ressonância magnética multiparamétrica. Mas, mais importante do que tudo isto é realmente a observação, a vigilância destes doentes. Estes doentes são habitualmente seguidos em clínicas de vigilância de cirurgia, portanto de diferimento cirúrgico, em que o doente chega no próprio dia, faz os exames laboratoriais, endoscópicos e imagiológicos necessários. Este doente está acordado durante a retoscopia flexível ou fibrosignodoscopia e este é o momento ideal porque permite não só falar com o doente, avaliar a função esfincteriana, esclarecer as dúvidas, enfim, criar-se uma relação de confiança porque, infelizmente, nós sabemos que alguns destes doentes vão ter um recrescimento, ou seja, um reaparecimento da lesão no local inicial onde existia o primário. Estes esquemas de seguimento são relativamente exaustivos no primeiro e segundo ano e depois obviamente começam a ficar bastante mais livres e até chegando a ser só realizados exames de ano a ano a partir do quinto ano. Como disse há pouco, nós temos que informar os nossos doentes que cerca de 1/3 destes doentes que atinge uma resposta clínica completa poderá vir a ter aquilo que se chama um recrescimento, ou seja, o reaparecimento tumoral. E muitas vezes é luminal, mas alguns deles não há aparecimento no lúmen ou na parede abdominal e há sim nos gânglios. Isto foi um trabalho que realizámos, avaliando a nossa série de doentes sujeitos a terapêutica neoadjuvante, em que, como podem ver cá em cima, na linha de cima, há um conjunto de doentes que, por ter resposta incompleta, foi operado. É o chamado grupo de cirurgia direta após radioterapia. E abaixo, os doentes que entraram em programa de resposta clínica completa, o Watch and Wait, em que neste grupo de doentes com resposta completa tivemos cerca de 29% ao desenvolverem o regrowth foram então operados. Como podem ver aqui neste quadro, não vamos trabalhar isto exaustivamente, mas só para vos demonstrar que no grupo de doentes submetidos a cirurgia diferida, ou seja, quando ocorria o recrescimento, houve 4 doentes que foi possível fazer a preservação do órgão, sendo submetidos a cisão TAMIS do recrescimento, houve um conjunto de doentes laparoscópicos e muitos robóticos. Mais ainda, como podem ver, nenhum doente foi submetido a laparotomia para operar o recrescimento e também não foi necessário fazer as entrações pélvicas nos recrescimentos. Obviamente há um número relativamente grande de abdominoperineais neste caso, nestes doentes, porque também, como também é panágio do Watch and Wait, é habitualmente limitado a doentes do reto baixo, com cancro do reto baixo, ou seja, 7 centímetros da margem anal, e portanto doentes que à partida, muitos deles, já estariam condicionados para fazer uma cirurgia de excisão total do mesoreto com abdominoperineal. Os resultados patológicos e oncológicos destes doentes não foram diferentes. Demonstrado isto, vamos passar então àquilo que o Tiago me pediu, que era mostrar um bocadinho o que se faz ponto a ponto nestes doentes. Já foi aqui discutido, usamos uma composição muito semelhante àquilo que foi anteriormente demonstrado para a cirurgia do cólon esquerdo. Muitas vezes eu coloco, além de uma abordagem inicialmente por um mini fan and steel com o Alexis S e depois a colocação das portas robóticas, mas em doentes obesos ou em doentes que sabemos que o ângulo esplénico provavelmente vai ser um bocadinho mais difícil, eu uso muitas vezes uma porta extra de 5 mm para o assistente poder ter 2 mãos e usar muitas vezes o aspirador de um dos lados e no outro poder usar uma pinça de preensão, colocar e retirar compressas, etc. Na prática, todos nós fazemos uma exposição muito semelhante, vamos fazer um Trendelenburg, vamos fazer uma exposição pondo o aumento para cima do cólon transverso. Isto pode ser feito laparoscópico ou robótico, de acordo com o facto de se temos uma mesa que permite a sincronização por Bluetooth com o robô, ou se temos uma mesa convencional. Muitas vezes, depois de orientar o intestino delgado, é utilizada nesta região, ao lado da aorta. Eu gosto de colocar uma pequena compressa, porque serve muitas vezes não só para limpeza, mas também para tração das ânsias e permitir a visualização. Não me vou demorar muito tempo, temos aqui a exposição, eu prefiro a abordagem inicial pela artéria, começo por identificar o dorso da artéria mesentérica inferior e retal superior, Muitas vezes isto é uma disseção que obriga a um cuidado extra devido aos plexos hipogástricos superiores, de modo a não haver qualquer tipo de dano nestes nervos hipogástricos superiores. De qualquer das maneiras, ao identificar a artéria, torna-se tudo bastante mais fácil e muitas vezes eu faço uma abordagem combinada em doentes sobretudo mais obesos, em que se faça uma abertura também do espaço e de entrada com a identificação da faixa de Tolt, também a nível da veia mesentérica inferior, antes de sequer de começar com a laqueação vascular. Isto permite-me desenvolver uma tenda suportada não só pela arcada de baixo da veia mesentérica inferior, como também a abordagem abaixo da artéria mesentérica inferior, e assim preservando, por um lado, não só os nervos, mas também evitando muitas vezes os danos laterais na artéria cólica esquerda, que muitas vezes sai daqui e muitas vezes provoca estas lesões. Nós preferimos sempre fazer a abordagem do vaso e a laqueação com um duplo hemolock, não gostamos muito de energia, e aqui, como podem ver, é uma abordagem relativamente standard, faz-se a laqueação na origem quer da veia, quer da artéria, com uma dupla laqueação, secção, e agora sim, com segurança vascular, fazemos a abordagem para portanto, a libertação de toda a faixa de Tolt, abordando também o pâncreas e a face inferior do pâncreas, desenvolvendo este plano, porque se torna muito mais fácil para enfim, a libertação do ângulo esplénico. Por defeito, eu sei que isto foi discutido aqui anteriormente, eu prefiro fazer sempre a libertação do ângulo esplénico, seja na reseção parcial do mesorreto, seja na excisão total completa do mesorreto. Eu acho que nos permite francamente uma melhora na anastomose sem tensão e por defeito fazemos sempre a libertação do ângulo esplénico nestes casos. Depois passamos para uma libertação de lateral para medial, até encontrarmos a nossa compressa, e deixando para o fim a fase mais difícil, que é sempre a libertação da cauda do pâncreas, expondo muitas vezes o baço e fazendo a libertação das últimas fibras. Por vezes, quando se torna um pouco mais difícil, temos que fazer uma abordagem também supramesocólica, libertando, portanto, fazendo o descolamento colo-epiploico, entrando na retrocavidade dos epíplanos, e isso sim permite-nos depois chegar então a bom porto e libertar totalmente todo o cólon esquerdo, todo o cólon transverso à esquerda, o ângulo esplénico e ter uma perfeita mobilização do cólon para a anastomose. Passando agora aqui à parte que o Tiago também me pediu. Isto trata-se de um doente nosso que teve uma resposta clínica completa, que posteriormente aos 18 meses, e portanto eu passo aqui a informação, 18 meses depois da radioterapia, foi necessário fazer uma cirurgia por recrescimento. Como podem ver, os planos são exatamente os mesmos que vimos há pouco, muito bem demonstrados pelo professor Hans de Wilde. O que estamos a fazer é uma cirurgia de acordo com os princípios do professor Bill Hilde, em que fazemos a cirurgia de excisão total do mesorreto, guiando-nos, como podem ver aqui, por um lado e por outro, pelos plexos hipogástricos superiores, mantendo então uma disseção pelo plano vascular, e como podem ver está um pouco mais de umidade, um pouco mais de fumo. É extremamente útil termos um assistente, um ajudante que nos coloca um aspirador fora do campo de visão, mas que por um lado nos permite também aqui a aspiração dos fumos e deste vapor. Há muito mais edema, como veem os planos estão um bocadinho mais, enfim, edemaciados, mas é possível fazer exatamente a mesma cirurgia, a cirurgia que estava prevista de início, fazendo uma excisão total do mesorreto, fazendo uma circunavegação. Eu prefiro sempre começar o mais posterior possível, libertar até já não conseguir maior mobilização posterior, depois fazer todo o lado direito, fazer a abordagem anterior e posteriormente o esquerdo, e com base nisto fazer quase como que uma evolução em espiral até chegarmos ao pavimento pélvico e à nossa área onde realmente queremos fazer a secção enfim, a secção com a máquina de GIA. Muitas vezes e preferencialmente usamos o agrafador robótico. Eu acho que nos dá muito mais segurança, dá-nos muito mais facilidade de manipulação, muito mais controle, mas em certos casos, nomeadamente em mulheres com uma pelvis mais larga, quando temos um ajudante ou um assistente bastante mais experiente, é fácil e muitas vezes podemos usar uma endogia XL através da porta do assistente e fazer a secção, ou então, como vos mostrei há pouco, dado que faço uma abordagem inicial por um mini Farand Steel e a colocação de um Alexis S com tampa, também podemos fazer uma abordagem através da tampa do Alexis e colocar a endografadora e fazer a secção do reto baixo através daquela região. Como veem aqui, já progredimos abaixo das vesículas seminais, bastante abaixo da próstata, estamos a nível do pavimento pélvico, fazemos a secção das últimas áreas da excisão total do mesorreto, temos o mesorreto todo isolado, já para cima, estamos abaixo do tumor, fazemos a agrafagem, e como podem ver, enfim, é uma pelvis um bocadinho diferente, veem que havia muito mais aderências, um bocadinho mais de fibrose, mas é possível fazer uma excisão total do mesorreto nestes doentes. Aqui um caso curioso, bastante mais interessante, mais bonito, é uma senhora que vamos fazer uma excisão abdominoperineal, não porque o recrescimento condiciona o pavimento pélvico ou porque atinja, enfim, o aparelho esfincteriano externo, mas porque se trata de uma senhora idosa, com quase 80 anos, com uma função fecal e defecatória já comprometida e que depois de radioterapia e depois do recrescimento achamos que uma anastomose baixa coloanal não seria a melhor situação para esta senhora. Aqui vem a vagina a ser afastada e retraída anteriormente, veem que os planos, apesar dos quase um ano após radioterapia, os planos são intactos e aqui, enfim, um bocadinho por curiosidade, vamos demonstrar a libertação do espaço interesfinctérico, em que eu liberto o pubo retalis, consigo levantar e isolar todo o aparelho esfincteriano externo do interno, e o meu ajudante está neste momento entre as pernas, a tocar na margem anal, e vamos progredir nesta abdominoperineal, diria extrema, interesfinctérica, não este levantador do ânus, em que vamos libertar a totalidade do reto e, enfim, torna-se depois muito, muito mais fácil. Estão a ver ali o toque na margem anal, isto é a margem anal, em que conseguimos ver a secção praticamente da linha pectínea. Enfim, quase todos os doentes são diferentes, isto obviamente é um doente muito favorável. Aqui já mostro uma situação um pouco menos favorável, estamos a falar de um doente que 9 meses depois da radioterapia tinha um recrescimento. Este doente tinha inicialmente um T4, com o atingimento do levantador do ânus à direita, e como podem ver aqui, depois da libertação de toda a faixa do mesorreto e fazendo uma excisão total do mesorreto, é possível, através da abordagem robótica, seccionar por cima o levantador do ânus ao nível quase da inserção esquiática, em que entramos depois na gordura e do espaço isquioanal, fazendo aqui a abordagem praticamente totalmente robótica de uma reseção extra-levantador do ânus por via robótica. Como podem ver aqui, estamos a seccionar, estamos a entrar já na gordura, na área da gordura isquiorretal, e portanto torna-se relativamente mais fácil depois, quando viramos o doente para prone, para fazer e para completar a parte, enfim, perineal desta operação, se já tivermos definidas as secções, enfim, mais complexas, torna-se tudo relativamente mais fácil. Apesar de tudo, é importante, quando estamos a falar em recrescimentos, explicar aos nossos doentes que não é só flores, não é tudo de cor-de-rosa, há problemas com os recrescimentos. Sabemos que quase 2% destes doentes que recrescem pode não ser resgatado, ou seja, a cirurgia pode não ser eficaz, ou porque eles abandonam os programas de follow-up do Watch and Wait e quando recorrem novamente à consulta e aos nossos hospitais vêm com queixas, com dores. Isto muitas vezes traduz-se em invasão local irressecável e intratável. Outros doentes em que infelizmente há o reaparecimento do tumor, ou seja, há um recrescimento com metastização concomitante, em que não há, enfim, não faz sentido nenhum fazer uma cirurgia do recrescimento quando há uma doença metastática disseminada. E finalmente há doentes que entram em programas do Watch and Wait porque são muito maus casos para cirurgia abdominal major, não têm condições para serem operados por cirurgia abdominal radical e quando infelizmente têm um recrescimento, continuam a estar, enfim, demasiado frágeis e com comorbilidades e muitas vezes não são candidatos a cirurgias destas, como vimos aqui, enfim, com as complicações associadas a todas estas cirurgias, como o ELAP, com a parte da infecção pélvica, etc, etc. Espero não vos ter amassado muito, agradeço mais uma vez o amável convite, foi uma honra e um prazer estar aqui. Tiago, não estou com a t-shirt porque foi roubada pelas minhas filhas, e muito obrigado a todos.
Ok. Thank you very much. The videos were amazing. You show us many different situations in this scenario of local regrowth. Before we proceed with the discussion, I would like to share a small video of 30 seconds from our sponsor, Johnson & Johnson, and then we will go on with the final session of the debate of this session about rectal cancer.
From cell therapy to robotic surgery, we're leading the way in healthcare, harnessing our strength in both medtech and innovative medicine to drive progress across the full spectrum of healthcare solutions. We're building a world where complex diseases are prevented, treated, and cured, and where solutions are personal. Every day, we profoundly impact health for humanity. We are Johnson & Johnson.
Okay, so I'd like to introduce our colleagues that will participate in this discussion. The first one is Leonardo Alfonso Bustamante Lopes. He's postdoctoral research fellow in colorectal surgery at Adventure Health, Florida, United States. Ana Maria Garcia, who is a member of our staff of coloproctology here in Hospital Moinhos de Vento, as well as Dr. Rafael Gitzman Dutravilla, who work here in Hospital Moinhos de Vento, and me, Thiago Leogesi. Well, I will start with Leonardo. Thank you, Leonardo. Do you want to address a question for any of our guests? Please go on. We cannot hear you, Leonardo. Maybe you are mute? No, we cannot hear you. Okay. Leonardo talk with our tech guy, and so I will call Ana Maria. Ana Maria, I believe that you want to address a question for Professor Handenwild, a friend of you, or whatever. What do you prefer?
Ja.
The word is yours.
Bedankt voor het mooie presentatie. And so I have two questions. First, about your video regarding the dissection of the rectum first, and the ligation of the vessels in a second moment. I think this is a bit different than what we learn usually in our training here. We usually take down the vessels first and then move to the rectal dissection and to the pelvis. And second is something that I was reading again over our notes that we made from your surgeries. And it's about the stapling, that usually we saw that you use one of the 8 millimeters from the robot that you change for 12 or 13 millimeters and then staple through that for a better angle, I think, and then use the 8 millimeters on top of the bigger one to continue the surgery.
Yeah, the thing about the vessels is obviously you can do that first, but I think it is a bit, it helps a bit to leave the specimen a little bit attached, gives a little bit of tension to move forward. And if you really take down the vessels first, then the specimen can be very floppy every now and then. So then it is sometimes more difficult, and you need the assistant to take it all the time and to hold it upwards. So this is the reason why I do the dissection all the way down, and then before we do the transection, we take down the vessels. So that's the only thing, is taking down the vessels for the very last part. And about stapling, yes, I mean, you push your specimen forward, so it's very difficult to get to take it with only one specimen, with only one staple. So you usually need two. I don't know, I mean, what the experience is of the other, of you, Dr. Figueiredo, I don't know. Can you manage it with one?
No, usually never one. I usually use two when I'm lucky. and I aim for 245 firings, because only in very, very exceptional cases we have women that can get down a 60 millimeter stapler on the pelvis. Otherwise, we usually try to measure it and gauge it for 245 firings. But sometimes, like you said, and like you showed, we need we need a third 45 firing for an extra large rectum. Yes.
Or any of you routinely or selectively use an extra trocar, maybe the one from the Lexia, to staple from anterior to posterior in a vertical line? What do you think about that?
If it's not very down in the pelvis, I mean, for a financial reason, I sometimes just use,
for example,
an endostapler, so not a robotic stapler, because it's. But usually you can do it just from the right lower abdominal trocar, but sometimes with the robot, indeed, you can go from a ventral position to get the angle better and to get the stapler down on the rectum.
Well, Tiago, for that, usually when I'm able, when it's low rectal cancers, I usually prefer to use the robotic stapler. I think we have more control, but for, price reasons, or if there's an issue with the robotic stapler, then for the low rectum, we might attempt with an endo-GIA from the Alexis port. Like I said, we don't use the umbilicus, so we don't use the axis from the umbilicus. We start with a 5 millimeter axis, fan and steel, and then we put the Alexis port, and then we put the robotic ports. And this way, we use that. So we can use that. It's very, very difficult to go from the assistant port because of the promontory. It's very difficult to go from the assistant port with an endo-GIA. Even with an extended endo-GIA, it will be difficult, at least in my experience. So usually we do that. Preferably robotic stapler for low rectums. If we cannot use a robotic stapler, then the fan and steel Alexis port, we can use that for endo-GIA. And if it's an upper rectum, we can use whatever we want because it's easy.
Great. Oh, Leonardo is back. Leonardo, do you want to?
I will try again.
The question for our guest.
Do you hear me?
Yes, we can hear you loud and clear.
Perfect. Thank you. First, congratulations for the amazing event and for everyone of the presentation. It was awesome to hear the experience of the participants. And I have a question about the comparison between the robotic surgery and laparoscopic surgery, because in my discussion with the experts, I have this problem that we try to compare robotic and laparoscopic like we did with laparoscopic and open surgery. So, the difference between open and laparoscopic, we already know. And now we are trying to do the wrong questions. We need to now explain the pain in the patient, explain when return to activities, and how detailed for the surgery and the comfort for the surgeon that you have in this. I want to hear your comments about how we can compare the robotic and laparoscopic surgery to prove what we already know. The robotic surgery have some improvements in that surgical procedure.
Shall I answer the question? Because, I mean, the line was not too good, so sometimes I heard only parts of your question. I mean, I think you're right. On the other hand, there are some comparisons, and especially the last paper that I mentioned which is recently published in the British Journal of Surgery, from high expert centers and very well trained laparoscopic surgeons who transferred to robotic surgery. And even in those centers, you can see the difference, not in quality of surgery, not in quality of specimen, not in the number of lymph nodes, not in the incomplete trisection margins or whatsoever. But the only difference is what you see is that they tend to more easily go very deeply in the pelvis with robotic surgery, and that is my personal experience as well. So that's the only difference you see, that they perform more low anterior resections, where they in laparoscopic or in open surgery perhaps went to an intersphincteric amputation, what Dr. Figueiredo just showed on the video. And which is not a big shame. I mean, sometimes it's a very good option in patients. So I think that is basically the difference. And yes, we have a better view, but it's very difficult to demonstrate better outcome in a sense that less sexual dysfunction or less urinary dysfunction. I think one of the best advantages we have with robotic surgery is for the surgeon himself or herself, that we have excellent ergonomics and that we can sit behind the console, and that makes it very comfortable. If I do robotic surgery for the whole day, I come home and I feel very fit. And if I do it laparoscopically, I feel exhausted.
Yeah, I totally agree. I totally agree with what Professor De Velde said. I might add something else, which is when Leonardo asked that you cannot show that to the patient. Well, it's a little bit like showing to the patients what have been the developments in car industry. I mean, of course, you can drive a car without the extras that we can now put in there, but for him or her, I think that we can add an extra layer of security. And I think it was also mentioned here some time ago that you have all these extras like indocyanine green and the Firefly option. So I think that in the future, a lot of the developments will come up in robotic platforms, and they will not be able to be transferred directly to laparoscopy, because probably most of us have been trained in open and then in laparoscopy and then in robotic. But probably also many of our trainees, and this is the last thing that I would comment, is that I find that robotic platform is the best training platform for TME. I don't know if the other panelists agree, but I think that that's probably the key and the thing for the future, is that we can simulate, we can integrate maybe even augmented reality and other things, and we will be better teachers, hopefully, than our masters were to us, that we can train and simulate.
No, I absolutely agree. And I show that in the video that if you sit next to your trainee, and it was actually the video, this was the reason why I demonstrated the video. You can point on the screen and you can say, okay, you have to go there. And you can't do it with laparoscopy because you have to assist. You have to help your assistant with the camera or hanging around and trying to help her or him. And with robots, you just sit relaxed next, and you can say, okay, I do it. Or if you have two consoles. So I definitely agree the advantage of as a teaching instrument.
Rafael Dutravilla, it's your time.
Good morning, everyone. Thank you, Thiago, for the kind invitation. As a beginner in robotic surgery, I feel privileged to be here and listen to this wonderful presentation. As a beginner, I have a lot of questions. I don't know how much of this you will allow me to do. So I'll start with a question to Dr. Nuno and Dr. Hans. What is the routine of in your service regarding intestinal diversion? Do you make diversion routinely or selective? And what is the criteria for that?
Well, for me, and I'll reply very briefly. If we are talking about TME, and if we are talking about TME after total neoadjuvant or chemoradiation, I always divert my patients. I know that now there's a trend to avoid that, but still I'm a very, how should I say, worried surgeon. I like to sleep better, and I always divert my TMEs. Partial mesorectal excision if you don't do any radiotherapy in my center, we usually don't divert. But if you have previous radiotherapy, even in a PME, we divert.
We are a little bit more. I mean, we had a very nice paper in the Netherlands, and it's called "Surgeons, Cowboys or Chickens," and the bottom line was that there was not a big difference in outcome, mortality, major complications between the two centers, and both centers had almost the same number of anastomotic leakage. So if you go and don't divert your patients, you have to have a good service. So I mean, in the Netherlands, we don't have the system like you work in 2 or 3 different hospitals, in a private and a community hospital. We have only one hospital where you work. You have a whole bunch of residents, surgeons who are on call. So it's pretty safe in the sense that everybody is just, everything is 24/7 available if you suspect an anastomotic leakage. So this is the reason why we tend to not divert if everything is fine, if you have a good healthy patient, ASA 1 or 2, so a non-smoker, if everything went fine with surgery, so the leak test is fine, your ECG is fine, so your perfusion is good, then we don't tend to do a diversion, even in radiotherapy treated patients. But this is different from a regrowth, what Nuno is saying, because those patients, and that is what you demonstrated, they are very often very, very firm, a lot of fibrosis. So those patients we will definitely divert.
Rodrigo, what is your practice regarding the diversion in mesorectal excision? You're mute. You're mute.
Perform a total mesorectal excision, 100% diversion. Partial mesorectal excision, we can think about, depends on the case. But the majority, no diversion.
Okay. Rafael, do you have another question? You said you have many questions, so...
Let me keep with the diversion. Dr. Nuno, do you prefer ileostomy or colostomy? Because we know that ileostomy in robotic surgery, it might be something tricky, and we have some pitfalls. What's your routine?
Well, trying again to be very fast in the answer. I was trained to do ileostomies, and I did that for many years. I've changed to colostomies now, transverse colostomies. We have a lot of papers showing the benefits of one and another. So I think basically, if you divert, I think you should do whatever you are most used to do with the safest technique that you can do. And then if you're not safe, then don't divert, and then you have to operate whenever you need. Yeah, and I agree with Professor Hans de Wild. The thing is that they have showed also in the Netherlands that they have a very good rate well, they have very good hospitals, trained hospitals, to rescue these patients from failure. So the failure to rescue rate is very low, and that makes the thing safe. If you are not sure on how is your response to that potential sepsis, then it's a tricky thing not to divert. Yeah, but I agree.
I have a question about the conversion, the urgent undocking. If our guests, Professor Nuno, Professor Hans, and Rodrigo, do you ever had this experience, or it was something that never happened to you, and this talk of Rodrigo was a good opportunity to learn something that you have never seen before?
Well, conversion to laparoscopy, yes.
No,
thankfully,
urgent
conversion to
bleeding.
Open, for bleeding, yeah. Well, most of I think that's again, not trying to get controversial. I think there's a benefit on going for the vessels first, because again, if you have not very good assistance, you might have you may increase the vascular lesions if you don't have good assistance with attraction, counter-traction. That's one thing for going vessels first. And I think that in the videos we show that potentially the IMV is the big problem, because when we are doing laparoscopy, we are in control of the tension, and this way we usually we go much further on the tent below the IMV. In in robotic, we tend to ligate the vessel first. So yeah, well, again for conversion, emergency conversion for open, not not experienced, but I've seen it unfortunately going live. I'm not sure if Professor Sanzaville was there, and I remember in one big meeting there was a rupture on the IMV on a live surgery, and that was a big, everyone in the room was like blank. And we always see that, and we get anguished when we see that thing happen, because we are all surgeons. But I think that's a good approach in the team. Try to simulate again, like the same thing that was shown in ATLES, in advanced cardiac life support. We must train the teams and the roles of the teams for the undocking and the emergency undocking, because we might have that. But so far.
Professor Hans?
Yeah, well, although it was in Portuguese, I could understand it very well, because it was a very nice presentation with all the instructions and the videos. So yes, we hadn't had the experience yet, but I think it's important to train, and I think we should do it at home and in our hospital. Although also, if you look at the data, it's very uncommon that you see conversions to open surgery in the robotic cases, and not only in the randomized trials, but also if you look at the data from the different hospitals that I just showed you, hardly ever do they convert to open surgery. If they convert, it's usually to laparoscopy, to put a clamp, or to that you can have some quick and some movements. That's potentially dangerous in robotic surgery. You have a small field. You have to have very, very nice and small movements, and that is the advantage of laparoscopy, that you can make some big swaps and big movements to control the bleeding. So yes, we had one patient where we converted to laparoscopy, but no open conversions yet.
Rodrigo, as the authority in urgent conversion in this panel,
I didn't have any case of emergency undocking, fortunately. But I have one important bleeding that I have to think about undocking or not undocking, but I could be able to stop the bleeding.
Okay, and what is your recommendation regarding the frequency that the team, the scrub nurses, the anesthesiologists, and the surgeons must do this training? How often you do in Mater Dei Hospital?
Yeah, I think there is no protocol for it. I think one in a year, every surgeon should be aware of the steps of undocking, emergency undocking, at least once in a year.
Great. Well, we are 18 minutes ahead of our time, but I would like to ask Leonardo Bustamante Lopes, if he can open his microphone again, to do the last question for our guests. Leo, we cannot hear you. I think your mic is closed.
So sorry. Are you hear me?
Yes, we can.
No, sorry.
Do you want to do the last question?
Sorry, it's a delay.
For our guest?
So the robotic surgery. Yep, I want us to discuss the last part of the regrow robotic surgery approach. And I was very interested in what happened when you have difficulty in that surgery, when you are inside the surgery and you have a lot of fibrosis and a lot of problems with that surgery. How is the approach? How fast you go to another open surgery or laparoscopic surgery?
Thank you for the question. Like I think it was presented here from Professor De Velde, that usually even very trained robotic surgeons, they take about 3.5 hours to do a low anterior section on a male patient. Usually that's between 3 and 4 hours. In regrowths, I think you need to pace yourself to even do slower, because for two reasons. First of all, you have we use special extraction like heated CO2, all the things that we can do. We use always two extra ports. So one 12 millimeter, it's the smoking evacuation and the heating for the assistant, a 12 millimeter. And we use, like I said in the beginning of my lecture, we also use a 5 millimeter port, a small 5 millimeter port for the assistant to use two hands. This way you can control one instrument for traction and the other one for smoke extraction. So we use more time. We have to be more patient because, first of all, there's more smoke, more edema of the fluid and from the tissues. The second is that the amount of tearing, so the rectum is less compliant. The fibrosis makes sometimes as hard as stone. So you need to take even smaller steps between all of that. And like you said, a little bit of blood, it's a small field, makes the surgery impossible. So we try to go slower and we try to circumnavigate more extensively. So we try to go slowly, elliptic, like an ellipse, trying to go there into the pelvis. But usually what I always say is this: a difficult surgery would be difficult open, laparoscopic, and robotic. Maybe, a combined approach with TTSS or TATME with robotic could help them. I have no experience in TATME, but some of my colleagues, they said it might be even easier. The thing is, you take your time, you don't rush, and you try to get the best vision that you can. And for that, I think robotic is the best approach for abdominal part, at least.
Thanks. Well, unfortunately, you have to finish the session. I would like to thank you, all of you. It was a privilege to have you this morning with us, sharing your experience. We are very grateful, and I hope in 2 years, in our 4th edition of the International Symposium of Colorectal Surgery of Robotic of Moinhos de Vento, we will have you again with us. So have a good day, have a good weekend, and thank you very much. Bye-bye.
Thank you.
Thank you.